Hello everyone. So in the last video we finished portal hypertension. In this particular session we would be starting with stages of hepatic encephalopathy, and we would continue and see how far we could reach within by the end of this video. I'm not particularly sure and I haven't planned to. It depends on what the how big the how huge the section is. So I can't really tell how big this megaloblastic is, as you explain and all that. It might take more time, some things might take less time and all that. So based on that, things vary, the timings vary. So let's begin with stages of hepatic encephalopathy. So before that, let's begin the timer. So this would be something similar to the previous videos: 50 minutes of studying, then 10 minutes of break. So we have the timer on. So definition: hepatic encephalopathy is neuropsychiatric. So neurology, psychiatric issues caused by, so what is the cause? Liver dysfunction leading to accumulation of neurotoxic substances. So liver is a purifying organ. So if it doesn't work properly, we have neurotoxic substances that are accumulated, and what are the substances? First one, pneumonia, and there are many others, but primarily need to know pneumonia. Ammonia, sorry, not pneumonia. Sorry about that. In the bloodstream, it manifests as progressive mental status changes, motor dysfunction, and altered reflexes. So three things: mental status, motor dysfunction, and altered reflexes. And it is classified based on severity, and there are four different classes, four different stages. And pathophysiology: liver dysfunction impairs ammonia metabolism, leading to neurotoxic. Same thing from the definition, we have brought it up here. And increased permeability of the blood-brain barrier, allowing toxins to affect the neurotransmission. So neurotransmission is affected. Glutamine accumulation in astrocytes leads to brain edema. So if you can remember from biochemistry, what does ammonia do? It leads to the accumulation of glutamine in the brain, and glutamine is mainly responsible for the bad things that happen in the central nervous system, in the brain. And what is the bad thing that is happening? Edema, brain edema. I don't have biochemistry section in this website, so in case there was one, this would have been an important question: glutamine and its effect on the brain. I think it was an important question in first year, but currently I am not exactly sure. But let's see in future, in case I find someone to develop the first year section, it would be included. Stages of hepatic encephalopathy. So we have classified it as different grades: grade 1, grade 2, 3 and 4. So first is mild confusion and behavioral change. So first stage is always the mild one, and here what do we see? We have classified the different domains into different sections. So the first one, mental status, alert and oriented but mild confusion. So mild confusion. Next one is restless and irritable. So even you have seen in dehydration, the first thing, some dehydration, there is restless and irritability, and even in other conditions where the first step is restless and irritability, then progressing on to coma and this thing, and probably over here it is the same thing. So in the first section, in the grade 1, it is irritable, restless, and at the end it is unarousable and coma. So this seems to be like a compensated response to toxin accumulation, but eventually if you can't handle it, it turns bad and goes into coma and unconscious state. Motor activity, incoordination and tremors are seen, and tone and reflexes are normal. Let's see if the mic is on. It's a big problem if it doesn't record it. Yeah, pupils are normal, and the when if you pinch, the patient responds to the commands, meaning he is responsive to pain. That's what it means. Clinical application: subtle changes in personality and attention deficit, reversible with early intervention. So that is grade 1, meaning it is mild stage where there is confusion, restlessness, irritability, incoordination, tremors, but he responds to pain and it is reversible. Second one, moderate confusion. So first it was mild, now it is moderate confusion, and motor dysfunction. Now even the motor system is getting affected. So coming back to the definition, there is mental status change and motor dysfunction. So motor disturbance started appearing in grade 2. Behavioral, there is combatic and euphoric. So combatic meaning fighter type and euphoric meaning mania like, and motor activity: yawning, grimacing, intention, tremors. So as you reach for the objects, he does this. Tone and reflexes: increased muscle tone and brisk reflexes. So hypertonia, response to pain, localizes pain stimulus. So pain this thing is still intact and pupils are hyperreactive. So we went from restless, irritable to excited state. So that is the second stage, is the excitatory phase. Clinical application: asterisks appear in this stage, which are the flapping tremors. So ask the patient to hold his hands forward and flaps appear. Those are the flapping tremors. Impaired ability to perform complex tasks. So complex tasks are impaired, which might be the case even in the first stage, but here it is more pronounced. Increased risk of falls and injuries. So as we have seen, it is a motor dysfunction, so even risk of falls and injuries. Coming to the third grade, which is severe cognitive dysfunction. So we went from motor dysfunction, and now it is motor impairment and severe cognitive dysfunction. So mental status: so cognitive dysfunction equals stupor, arousable but disoriented. So he can't function normally anymore. So disorientation is a key feature, and sleeps most of the time, marked confusion. And coming to motor activity: decreased movement and increased tremors. Movement is decreased, which is a motor impairment. So I am connecting whatever there is, like all the points, to the headings, so that if you remember the headings, hopefully you can answer the question. Similar in the sense, same thing applies to me, meaning even I am studying for my exams. So just in case I write the question, write the heading, I will be able to write all the points related to it. Tone and reflexes: upgoing plantar reflex. So Babinski's sign and clonus present. So upgoing, so usually what is the norm? Keep forgetting. Fanning of toes, yes, upward, meaning it is a normal state. This one, upgoing plantar reflex, that means upward, and fanning of toes, which is a good one. And clonus is present, but clonus, this is the negative, clonus is present. And response to pain: flexes limbs to painful tremor. He can still experience pain, but since he is in disoriented state, he can't talk about it. And this is hippus. We need to know what hippus is. Yeah, so hippus is rare neurology that causes pupil to move erratically, dilating and constricting in rhythmic pattern. Next, coming to what are the clinical implication: severe asterixis, hyperreflexia. So we have seen this. So asterixis started in grade 2, now it has progressed to grade 3. Marked impairments in verbal communication. So he is disoriented, right? So because of that, he can't talk properly, and then requires hospitalization in intensive care, which is obvious, like he can't function normally anymore. Now coming to grade 4, coma and neurological dysfunction, the final stage, final grade, where is unconscious, no response. Coma in case of mental state, behavioral, it is unconscious, and motor activity is absent totally. Tone and reflexes: sustained closure, decerebrate, posturing. We have seen what decerebrate is, so which is here, extensor response. So we have seen the person is completely extended, he has extended everything, and that is what the response to pain is, and that is what the normal state is. and pupils are dilated and sluggish, but earlier it was hippus. Grade 3 equals hippus, grade 4 equals completely dilated and sluggish. Yeah, and clinical implications. I'm just imagining if a person who is taking the practice has seen this particular video, and this is a side this thing, okay, if you have seen this video and just ask me the same question, just in case I can't remember, I'm imagining what the state is going to be like. Anyways, clinical implications: high risk of brain edema and respiratory failure. So brain edema and respiratory failure, so this thing is already we have seen in the pathophysiology. And respiratory failure meaning if the respiratory centers are affected, then that is a problem. And also the patient coma, right? So maybe some kind of this thing on the inside, like he might not be able to breathe. Yeah, same thing, respiratory centers being affected. Then coming to management. So management, we have given a very short section over here because the question is on different grades. Even in the previous years it has been asked different grades of this thing, what is it, hepatic encephalopathy. Management in detail, I think it's given in this one, what is it, in medicine, but for this particular case we are mainly looking at different grades, that's it. But overall better to know the management. Correcting precipitating factors, which includes infection, GI bleeding, electrolyte imbalance, which are seen in this one, what is that, liver problems, meaning some are causes, some are effects. So this one could be a cause and could also be a precipitating factor. This could be a complication. This one could be a complication. Lactulose therapy. So lactulose, it's this thing, it acidifies the gut and leads to reduced ammonia production. Acidifies meaning increasing H plus in the gut, and this H plus binds to NH3 and it becomes NH4 plus, and this is ionic state and can't be absorbed. Coming to rifaximin, to alter gut microbiota. So this kills the bacteria that produces ammonia. Protein restriction in acute cases but adequate nutrition in chronic cases. So this one, protein restriction meaning proteins are responsible for mainly ammonia generation, so you restrict it in an acute case, but if you see it in longer this thing, you can't just leave it there with protein deficiency, it is bad. So in that case you keep continuing this thing, protein. And liver transplantation in very bad situations. Coming to the last question in GI and liver, what is WHORS? So it has a specific grams per liter, this thing, separate constituents, like there are certain constituents to WHORS and certain electrolyte content. So based on that, this specific thing has been designed and it has been included in our curriculum. So this is important even in this one, community medicine, as you all know. It's a low osmolarity rehydration solution used to treat dehydration caused by diarrhea, and it can also help in other things which are mentioned over here, and it prevents complications like hypovolemia, acidosis, electrolyte imbalances. So what are the uses? Let's see them before we go into the composition. Treatment of mild to moderate dehydration caused by acute watery diarrhea, which is main function and main indication. Prevention of dehydration, acute gastroenteritis, almost similar. Rehydration therapy in cholera, rotavirus, diarrhea, almost similar. Management of electrolyte imbalance, and then coming to replenishment of fluids in heat exhaustion and excessive sweating. So next, coming to the composition. So we have already seen this earlier in the acute watery diarrhea section, or maybe persistent diarrhea. Acute watery diarrhea, because in persistent diarrhea we have seen the different diets. There is plan A, plan B, plan C. Some has less of protein, some has more. Remember, yeah, that one was for persistent diarrhea. In this particular case, this is acute watery diarrhea. So this repeats over there too, and we have seen it. So we won't go in detail, like 2.6, 13.5. Like this requires memorization, so we can't go in detail to 1.5 and 2.9. These are the constituents: sodium chloride and glucose, potassium chloride, trisodium citrate. And then coming to electrolyte content, repeats for sodium chloride and glucose, and decreases drastically in case of KCl and trisodium citrate. So 20 and 10 overall coming to with a total of about 245. What are the key features? Low osmolarity enhances absorption, water absorption, balance sodium and glucose for optimal rehydration. Reduces stool output and vomiting, safe for all ages. So these are the key features. It's fine if you can skip, if you skip this, meaning the question is about this thing, right? Mainly it would be associated with composition uses and contraindications. So what are the contraindications? Or else you can write this, you might get more marks. Contraindications. So WHO ORS is contraindicated in severe dehydration and shock, because in that particular case you are going for a this thing more higher advanced therapy, which includes intravenous fluid resuscitation. Uncontrolled vomiting, because it is the same oral route and the patient might not tolerate it. So same thing, IV fluids. Severe hypernatremia. So in that particular case this thing is not sufficient, the sodium levels over here. In that particular case what we do is specialized fluid formulations. Then there is paralytic ileus. ORS is ineffective because absorption is impaired. So absorption is gone, so there's no point. Glucose malabsorption, in which case as you guys know, it is sodium and glucose coupling that takes place to maintain the balance. So and the glucose malabsorption is the main thing, you don't do it. And then conclusion, you can read this, but now I am going to close this, and we have come to the end of the discussion of GI and liver. Now coming to hematological diseases. This is actually, if you think about it, if you have gone through your previous years, meaning first, second, third years concepts properly, this should be very easy. So megaloblastic anemia, that is the first one. So megaloblastic anemia is a macrocytic anemia caused by deficiency of B12 or folate, leading to nuclear dysmaturity and ineffective erythropoiesis. So two things. So this can apply to everything, all the cell lines. This can affect, this means RBCs. So what do we have? We have 4 RBCs, large red blood cell, which is known as macrocytosis, and in all the cell lines particular part we have hypersegmented neutrophils. And when you look at the bone marrow aspirate or the smear over there, you see erythroid hyperplasia. So what are the causes? It could be decreased intake, increased requirements, impaired absorption and drug induced. So generally it applies to most of the anemias, similar this thing, dietary anemias. So vitamin B12 deficiency, so specifically it could be due to strict vegetarian diet. As we all know, strict vegetarian diet, it doesn't have enough of B12, and then malnutrition, wherein you don't consume anything in the first place. Then there is folic acid, infants consuming specific foods which are low in folate. Then coming to, and I think this one, I think folate is more in plants and veggies. Let's see that once. Folate deficiency in less consuming. Sorry for the grammar, I am not thinking about this, I am just thinking about the concept. Consuming of veggies. Yes, if you don't consume enough of vegetables. So one is folate is less vegetable consumption, this is less meat consumption. So in second one, increased requirements. So input is normal but use is very high. What are the conditions? Infancy, pregnancy, chronic hemolytic anemia, wherein turnover is high and cells are rapidly getting destroyed and you need more replacement. For those replacement we need raw materials. Raw materials are not enough because those raw materials are for normal homeostatic phase state. Next, coming to impaired absorption. Impaired absorption, what are the conditions? Intrinsic factor deficiency, as we all know, it is important for B12 absorption in the ileum, and in case of pernicious anemia, the intrinsic factor is not there, which is secreted by, I think, parietal cells. Yes, parietal and parietal cells secrete HCl and intrinsic factor, which are missing in pernicious anemia. Celiac disease, Celiac disease, in this particular case there is malabsorption. Yes, it is a malabsorptive state, and then there is other malabsorptive syndromes. So in case you remember, you can list all of them to make the answer look bigger. Next, coming to drug induced megaloblastic anemia. So drugs causing megaloblastic anemia. So what are the drugs? There are PPIs, phenobarbital, phenytoin, methotrexate, trimethoprim, pyrimethamine, and other anti-cancer drugs. So PPIs, cobalamin, B12 absorption is impaired. Next, coming to phenobarbital and phenytoin, impaired. P for phenytoin, FENYTOIN, phenytoin for folate, FOLAT. And then there is this cotrimoxazole, which is its primary mechanism of action is inhibiting the folate pathway, dihydrofolate reductase, where because of which, and that is the key feature, right, wherein in both of these folate pathways only, but one has different mechanism than the other, but overall it is this thing, impaired use in rapidly dividing cells. Okay, this in this particular, it's for bacteria. In this particular case, this is bacterial, this thing, yeah, this is in case of human. So overall there is interference with folate metabolism, that is the key. And other things include anti-cancer medications. As we all know, anti-cancer, it is more of rapidly dividing, and what do rapidly dividing cells need? Lot of folate, yeah, folate and B12. Coming to pathophysiology, as we have already seen, impaired maturation and defective DNA synthesis, and B12 is required for folate recycling. So there is a very good flowchart in biochemistry. In case you have time, you can go through it. Methylation of and methylation of DNA nucleoproteins. So B12 is required for two things. One is for folate recycling. So this is required for this, also for this. Deficiency lead to delayed nuclear maturation and premature cell death. So we have seen this, and nuclear maturation is impaired. One second. Sorry about that. Coming back, yeah, so deficiency leads to delayed nuclear maturation and premature cell death. So nuclear maturation is very important for the cells to look normal. If the cells don't look normal, they die prematurely, and that is a key point. Overall, multiple key points. And despite active erythropoiesis, anemia developed due to ineffective erythropoiesis. Erythropoiesis is happening, but it is ineffective. So because of that, there is anemia. So key points: DNA synthesis is impaired and nuclear maturation is happening. Then there is folate recycling, that is having problems, and also methylation of DNA nucleoproteins, for which B12 is required, and delayed nuclear maturation results in premature cell death, and deficiency results in both, but overall it is this is the end point. And because of premature cell death, which is anemia, lysis, leads to anemia overall. And despite active erythropoiesis, it is ineffective. Coming to clinical features, there are general features. So already discussed, you can't associate this to any specific specific type of anemia. Anemia, anorexia, weight loss, irritability, fatigue, this can be everywhere, even in infectious conditions. So what specific do we look for? In this particular case, specific to B12 deficiency, we have neurological symptoms. Why is that? It is because of myelination. So B12 is required for the myelination of the peripheral nervous system, and loss of position and vibratory sensation is the symptom, and memory loss is also seen. posterior and lateral columns deficit, which is known as subacute combined degeneration, SCD for short, and neuropsychiatric symptoms. So see, these are the key points for vitamin B12 deficiency, and these are not present in case of folate. And it is important to know that before I go on over to the treatment, to know that in case you are confused, meaning in case you are not particularly sure whether it's B12 and folate, you need to make sure that you don't give folate before B12, because it can worsen this deficiency and cause worsening of these symptoms. And neurological symptoms, as you all know, are very difficult to once you get those, it's very difficult to reverse those. So make sure that you assess which one it is properly. Next, coming to dermatological signs, there is hyperpigmentation of skin, especially knuckle and terminal phalanges, that is glossitis and stomatitis. So this is generally like seen in so many other conditions, and it would be hard to remember, but still, hyperpigmentation of skin, hyperpigmentation meaning darkening of skin, and glossitis, stomatitis, which is seen in so many other anemias and micronutrient deficiencies, vitamin and micronutrient deficiencies, and growth and developmental delay, tremors and delayed milestones in children. And coming to the management, this one, what is investigations and management. So a specialized test known as the Schilling test, I am not covered in detail over here because it's a specialized, a very nice question in medicine. So you can go through in medicine, I'll just mention it over here. For details, go to medicine. In medicine, the megaloblastic chapter section has very good detailed explanation on Schilling test. Coming to the investigations in general, CBC, obviously, because we need to know whether RBCs are less in number, and we need to know red cell indices, and in that particular case MCV is increased. So what does it mean? Increased greater than 100 femtoliter, that is the size increase. So 80 to 100 is normal, greater than 100 equals macrocytic anemia. Pancytopenia, because all the cell lines are affected, because B12 and folate are required for DNA maturation, and DNA is required in all the cell lines. DNA maturation is required for all the cell lines. And peripheral blood smear, hypersegmented neutropenia, I need to take this off, this got added, and macrovalocytes, which is large round cells. Bone marrow examination, we have hypercellular bone marrow, erythroid hyperplasia, and that is as a compensatory mechanism. Coming to the serum studies, low vitamin B12 and folic acid levels, and elevated LDH and bilirubin, because they keep getting broken down. And B12, this is obviously the case. And Schilling test, at should I go through it now itself? No, we will see in the medicine when I am taking that. Now we need to, because in pediatrics specifically, if you include a Schilling test, this won't be a 5 marker anymore, it will increase, the size of it will be much bigger. But anyways, if you want to include, you can. Treatment, so there are these vitamin supplements, and then management of complications and supportive therapy. So folic acid vitamin B therapy, there is folic acid 1 to 5 milligrams per day for almost a month, 1 to 5 milligrams a day, 1 to 5 folic, F for folic, and 1 to 5 starting from F. So folic, folate, phenobarbital, phenytoin, continued for 1 to 2 months for body for restoration of storage, 1 to 2 months, 1 to 5 milligrams per day, 1 to 2 months. Vitamin B12 is 500 to 1000 microgram. So this is milligram, it's a microgram, and this is IM. So injections given on alternate days for 2 to 3 weeks. Why is that? Because severe complication that is associated with it, followed by maintenance therapy. And this is also included in this, like all these oral and all that. So this is somewhat important, 500 to 1000 microgram IM, that is 1 to 5 milligram per day for 3 to 4 weeks, this is 500 to 1000 microgram. Management of neurological complications required B12 injections every 2 weeks for 6 months, then monthly for life. That's crazy actually, it's very sad. And supportive therapy, So ensure that nutritional support is maintained. So not meat, fish, dairy and green leafy vegetables for both, and monitor for anemia, monitor responsive for anemia unresponsive to therapy. Indicate metabolic disorders, example homocystinuria. Next, coming to the iron deficiency anemia. So in this particular section we will be looking at the investigation and the treatment only. So coming to the investigation specifically, investigations: CBC, hemoglobin is reduced, RBC, total red cell count is reduced in this particular condition, microcytic hypochromic anemia, and then peripheral blood smear. We look at microcytic hypochromic red cells, small cells, very small cells, less than 80 femtoliter, and anisocytosis, poikilocytosis, different shapes and sizes, and increased red cell distribution width, meaning as the time passes, because of variability in iron stores, the sizes are also different. So red cell distribution width, so the gradient is very high, but it is not the case with other microcytic anemias. In case of thalassemia, the gradient is less, and all the sizes, because it is a qualitative disorder, not qualitative meaning in terms of this thing, what is it, the sizes, it is the same everywhere because it is a genetic condition. But here this is because of nutritional, because the stores are less, the gradient is different, and because of that the width, what this thing is available, the variability is very high. And serum iron studies less than 75 milligrams per deciliter, and ferritin less than 15 nanograms. So I think you just can mention the serum iron levels being less, and iron binding and ferritin being less, because stores, and this is the active which is actively available. And increased TIBC, which is obvious, because TIBC refers to the total iron binding capacity, how much is the capacity of the body to bind iron. So in case there is lot of iron, the capacity itself is less, but if there is less iron, the capacity is more, you can bind a lot more iron because there is less iron in the first place. And reduced transferrin saturation. So saturation, this is the opposite of this. Transferrin saturation refers to how much of transferrin has been saturated with iron. So in this particular case, saturation is less. Why? Because the thing that is causing the saturation is not there. Reticulocyte count, normal or slightly increased, and if you give transfusion, the rate of erythropoiesis increases rapidly and the reticulocyte count increases. Next, coming to investigations. So chest X-ray, electrocardiogram to assess cardiomegaly, and bone marrow studies, decrease sustainable iron. Stainable iron. So in that particular case, you do a particular staining. I think, what is it called? Bone marrow staining. Is it Albert stain? No, something else. Prussian blue. Yeah, Prussian blue. That's the word. Prussian blue staining. So that shows that this thing has less of iron in the bone marrow for erythropoiesis, but you rarely do it because it is obvious looking at this thing. And then looking at the treatment, oral iron therapy, ferrous sulfate 3 to 6 milligrams per day. Need to make sure somehow remember the dose. Ferrous sulfate 3 to 6 milligrams per kg per day, 3 divided doses for 4 to 6 months. This thing in 3 divided doses, so divided by 3, so 1 to 2 every dose for 4 to 6 months. So 1 to 2 milligrams per kg per day, not milligrams per dose, 1 to 2, and it is per dose, so 3 doses per day lasting for 4 to 6 months. So that might have made the thing easier to understand. Best taken on empty stomach. So empty stomach is the keyword. Empty stomach. Vitamin C enhances the absorption. We have already seen this in the scurvy section. And constipation, diarrhea, and staining of teeth. Parenteral iron therapy for severe and malabsorptive causes. So parenteral, because this thing gut is not functioning properly, right? So because of that, or else you need a lot of it. So a lot of it you can't directly give it through the oral route, because a lot of it is wasted in the this thing. Wasted meaning it this thing passes off through the stools. So in that particular case, you give parenteral. Indications: intolerance to iron, chronic blood loss, and severe deficiency. Available forms are dextran, sucrose, and ferric carboxymaltose. These three words. First one was sulfate. Here it is dextran, sucrose, and carboxymaltose. And blood transfusion given in emergencies less than 3 to 4 grams per deciliter. Slow infusion of packed red blood cells, which is 5 to 10 ml per kg at birth. So 3 to 4 grams per deciliter, which is a very very low of hemoglobin. In that particular conditions, you give this thing, and you need to include this one, hemogram. In this particular case, the levels, I think that would be better to classify different states, but if you want it in detail, it is there in medicine. Where is it? And slow infusion of packed red blood cells, 5 to 10 milligrams ml per this thing. Response to therapy, time for administration and response. So within 12 to 24 hours, irritability and increased appetite. So and then 26 to 48 hours, erythroid hyperplasia. So and then it's like one day, within 1 day there is irritability, the behavioral this thing improves, and within 2 days the bone marrow response is seen. Within 3 days there is increase in retic count, and within 1 month increase in hemoglobin counts. Within 3 months, full replacement of the stools. So 1 day, 2 days, 3 days, 1 month, 3 months. So within 5 things. First one is behavioral symptoms improve. Second one, erythropoiesis improves. Third one, retic count improves. Fourth one, hemoglobin count improves. Last one, replacement of stools. Prevention: exclusive breastfeeding, which contains iron, and iron supplement for low birth weight infants for 2 months, and iron rich diet, and national anemia control program. This one you can read the conclusion later. Next one, coming to hemolytic anemia. We have 13 minutes. Let's see how far we can go. Definition: hemolytic anemia, it's a group of disorders. So it's not just a single one, a lot of things can cause it. Accelerated rate of RBC, let's see how much there is. So here we are looking mainly at laboratory diagnosis of this one. What is it? Hemolytic anemias, because in pediatrics this was the important thing. What do you say? Important section in hemolytic anemias. Sorry, and it can be, the causes could be inherited or acquired. Inherited include intrinsic defects in the RBCs. Acquired includes external destruction. And laboratory diagnosis, there are multiple things: retic count and accelerated erythrocyte destruction. For that there are different tests. And for accelerated erythropoiesis, so it is getting broken down, right? So if the breaking down process increases, the production process also increases, and for that we have this. For the breaking down process we have this, and for the etiologies we have separate tests. So the first one, retic count, determines the rate of production in response to anemia. Increased count that is greater than 2%, meaning every 100 RBCs what the retics are, reticulocytes are. It suggests compensatory erythropoiesis, helps differentiate between hemolytic and other anemias. And next one, laboratory signs for accelerated erythrocyte destruction. So how fast they get broken down. So in this particular case we have LDH and all that, which the markers. So fall in hemoglobin greater than 1 gram per dl per week. So today you have 16, but next week you have 15, next week you have, week after that you have 14, a week after that 13. Just to elaborate more on this particular point, increased serum levels of unconjugated bilirubin, which is a byproduct of heme breakdown, and which can show up as jaundice. Increased urinary urobilinogen excretion, which is working fine, meaning the process of excretion of bilinogen and all that is working fine, urobilinogen. You see this increased serum LDH, which is a direct outcome of hemolysis or lysis of any other cell, and reduced haptoglobin and hemopexin levels. So haptoglobin binds to free hemoglobin. So whenever you have lysis, the free hemoglobin binds to this, lot of hemoglobin is available and it binds to all of this, and then the amount of this is similar to transferrin and saturation levels and all that. So whenever you have increased of the substrate, this quantity reduces, this thing is there, right? This quantity is less. Its depletion indicates hemolysis. And then increased glycated hemoglobin due to shortened RBC lifespan. This I am not particularly sure. Let's check this. Why? Longer lifespan, more time for glucose to bind to HbA1c, less exposure, so lower. When it could be increased, hemoglobinopathies in certain conditions affect certain RBC population and oxidative stress, rapid turnover of RBC but exposure to higher glucose in circulation. So it varies, you can't actually tell about this point, but it was included in the textbook, so it is mentioned here. Decreased erythrocyte lifespan, so less than 100 days. Next, coming to increased erythropoiesis. So even the increased this thing, first one is the retic count obviously, but it is mentioned separately because it's a very important marker and it requires its own heading. Bone marrow compensates for RBC loss by increased RBC production. So that is peripheral blood findings and bone marrow findings. We have two, and peripheral bone finding as polychromasia, which is increased immature RBC with residual RNA. So there is, you can see the red blood cells with a lot of RNA in it. So RNA is stained as blue on HND, and reticulocytosis meaning increased retic count. So this is this one, okay, this one peripheral blood, and then macrocytosis, enlarged RBCs could be seen, and increased nucleated RBCs in peripheral. So what the thing is behind these two, this thing is the maturation is directly linked to what the size of RBC is. So if the size I think is 7 micrometer or something diameter. So what happens is, in case the maturation happens normally, the size should be this, but in case there is lot of breakdown and all that, the body needs red cells, but maturation time is not enough. So these big cells with this one, what is it, a lot of nuclei and RNA and all that. So end product doesn't have nuclei, doesn't have RNAs and all that, but the meaning the younger cells have all of that. But when the body needs it, the younger cells are thrown into the bloodstream. So because of that, these younger cells appear in the peripheral smear and they look macros, meaning big cells. So that means these are younger cells, and increased nucleated RBCs meaning meaning these have nucleus, and these, it means these are younger cells, because at the end the normal RBC doesn't have nucleus, doesn't have RNA. And I think in some of the diseases there is this thing specified, basophilic, all that, inclusions, not inclusions, Howell Jolly bodies and all those are characteristics of immature, right, Howell Jolly bodies. The spleen isn't functioning properly, megaloblastic anemia. Remnants of DNA, normal. So see, remnants of nuclear DNA. So you don't want the nuclear DNA, you want them out, because the normal RBCs don't have those. But when you have those, I am spending too much of time on this because I deviated, shouldn't have. But this one is actually very interesting, how the maturation works and all that. Next, coming to bone marrow findings, there is erythroid hyperplasia. Looking at the bone marrow specifically, we were looking at peripheral smear earlier. Now bone marrow, there is erythroid hyperplasia, meaning RBC precursors are high, increased iron turnover. So whatever iron is there, it is getting depleted and getting used super fast, and increased plasma ion turnover. So even in terms of plasma, so ion turnover, because it is rapidly getting used. Next, coming to feature specific to different anemias, hemolytic anemias. So peripheral smear findings, and then there are Coombs tests, then there are for hemoglobinopathies and all that. Regarding hemoglobin specifically, we have different tests, different findings. So malaria, we have plasmodium species inside RBCs. So depending upon what kind of malaria is, you could have different shapes of the parasites in the RBCs. By itself, seen in G6PD deficiency, because G6PD deficiency, there is oxidative stress leading to the cells getting bitten off by the macrophages. Spirocytes, hereditary spirocytosis, where the spectrin is has problems and the cell wall has problems, not cell wall, cell membrane has problems, and because of that they get destroyed very easily. Next, microcytes with fragmented RBC. So in this this is microcytic anemia because of thalassemia, which we are going in more detail in the next section, next set of questions. Thalassemia and spirocytosis also is included, sickle cell is also there. So we will see. In general, this is a very interesting and an easy section actually, but it's hard to write answers because you need to remember so many things. Coombs test, schistocytes. These are in, so what happens is these cells, because of DIC and all that, what happens, it is vascular system is there, right? The vascular system causes because of the thrombus and all that, there is shearing of RBC membrane, and the RBC membrane, it changes its shape and they look like helmets, and these don't look like normal RBC oval side biconcave type at all, and that is in these specific conditions, DIC, HUS and TTP. Coombs test, so this is autoimmune type for all those to detect what it is. So help determine hemolysis immune mediated or not, positive in AIHA, autoimmune hemolytic anemia. Then there is hemoglobinemia, hemoglobinuria, hemosideruria, present in intravascular hemolysis, unconjugated bilirubin, LDH and retic count are elevated in both intravascular and extravascular hemolysis. This is in general. So this is mentioned large, but this is also important, present in intravascular hemolysis, which these things. Hemoglobinemia, hemoglobin in the blood, in the urine, and hemosideruria. I think it is related to, I can't exactly recall. Hemosiderin present in the urine. Hemosiderin is the storage form and it is present in the urine. So we have come to the end of discussion on these three things. Next, coming to hereditary spirocytosis, which is a genetic condition and where there is defect in RBC cytoskeleton, where there is decreased red cell membrane stability. So membrane stability is impaired, and why is that? We will be looking at here. premature red blood cell destruction because of this thing, and chronic hemolysis. These are key features which we need to remember in hereditary spherocytosis. HS results from deficiency or defect in spectrin, ankyrin and band 3. These three things, spectrin, ankyrin and band 3, which play vital role in RBC shape and stability. And they lose their shape, becoming spherocytes, which are more rigid and prone to destruction in the spleen. So spleen, as you all know, it has a lot of sinusoids and all that, and there are a lot of trabeculae and all that. So the cells need to pass through it very easily. The RBCs pass through it very easily when it is biconcave, but when the membrane has problems, it doesn't pass through it properly. It's very stiff, rigid, and what because of that it breaks off and dies easily. It's autosomal dominant, which means parental alleles, even if one of those have this particular mutation, it is expressed. But even AR, autosomal recessive traits exist, forms exist. Then clinical features, it manifests during, yes. So clinical features, we'll be taking a break now, and then we'll be coming back and discussing the clinical features of this one. So for now, I'll turn off the mic and the video, and you can also take a break. Welcome back. So let's start the timer again. So coming to the clinical features, HS manifests during infancy or childhood because it's a genetic condition, meaning autosomal dominant genetic condition and affecting RBCs. So what is it present with? Hemolysis and anemia, and there are different sections over here. So one is hematological, which is the main thing that is affected. Hepatosplenic manifestation and skeletal and gallbladder functions that are features that are seen. So first one, hematological. So anemia, obviously, because it is getting the cells are getting broken down very easily. Fatigue and exercise intolerance, pallor and weakness, like general anemia features. Intermittent jaundice due to increased bilirubin levels, so jaundice, and hemolytic crisis triggered by infections. Then specifically in infectious state, when the patient is suffering from an infection, this thing increases, the hemolysis increases. And hepatosplenic manifestations, splenomegaly, hepatomegaly, mild to moderate in first year, worsens with increased hemolysis, and hepatomegaly in severe cases. Skeletal and gallbladder functions, so there is frontal bossing, pigmental gallstones. So these pigmental gallstone increased breakdown of RBCs, the hemoglobin, this thing is broken down into this one, what is it, bilirubin, and because of that bilirubin we have pigmentation, frontal bossing due to extramedullary hematopoiesis. Bone marrow production is not enough, so extramedullary, outside bone marrow, outside the marrow. Then cholelithiasis in older children. What are the complications? There is aplastic crisis. So specifically we have the organism parvovirus B19, when you have this, there is aplastic crisis in hemolytic anemia, leading to this one HS, hereditary spherocytosis, leading to sudden worsening of anemia. Hemolytic crisis, which as we have already seen, is triggered by infection causing increased hemolysis, gallstone formation due to chronic bilirubin elevation. Now coming to investigations in detail. So there are blood tests, peripheral blood smear, and special tests for this thing, and then there is diagnosis of specifically what are the key findings overall. So hemoglobin in general, it is less, so 6 to 10. You can't differentiate what kind of anemia it is. MCV is decreased, less than 80 femtoliter. MCHC increased, which is a hallmark in HS, so which is here mentioned here again, MCHC. And then retic count is high because it's a compensatory feature. Increased hyperbilirubinemia, as there's a cell breakdown is happening. LDH is increased because same thing, cell breakdown. Haptoglobulin is reduced because free hemoglobin is lying around in the blood, which binds to the haptoglobulin. Peripheral smear and spirocytes are seen, small round RBCs lacking central pallor. So this thing around what is the spirocytes versus normal. So this one is fine. You can see the central pallor is missing and these are circular, whereas central pallor is present in normal RBCs and these are biconcave, concavity on two sides. Next, coming to polychromatophilic reticulocytosis. So indicative of bone marrow compensation. So bone marrow is compensating for these this one, what is that, lack of RBCs by releasing reticulocytes which have RNA in them. So as I've already mentioned, the maturation is indicative of how the red cell looks. So in case if it looks big with basophilic components, it means it is immature. So this is mentioned here. So also, where is it, the diagnosis? Yes, spirocyte with retics on blood smear, that is also diagnosis. And coming to special test, osmotic fragility testing. Over there you can see increased fragility in hypotonic solution, and there is EMA test. Eosinophiline melamide test confirms HS. And coming to the diagnosis, finally, like genetic conditions, so positive family history, it's seen repeatedly because it is autosomal dominant. Anemia, jaundice, splenomegaly, which is a general feature, and spirochetes and retics on blood smear, and MCHC is elevated. And differential diagnosis. So what are the other conditions that look like this? ABO incompatibility and HDN, hemolytic disease of the newborn, autoimmune hemolytic anemia, burn related hemolysis, and Clostridium perfringens septicemia. Next, coming to treatment. So there is general management, definitive management, and treatment of complications. So first we look at general management. So support the erythropoiesis. How? By folic acid. And blood transfusion is required in severe anemia cases. Then there is monitoring of gallstones and aplastic crisis. So here folic acid, this thing, specifically B12 is required in the maturation cycle, in specifically for recycling of folate. So when if you give enough of folate, it is very good. Now coming to this one, what is required in severe anemia cases, and monitor for gallstones, because it is getting broken down. Red cells are giving rise to, the hemolysis is giving rise to a lot of bilirubin. Next, coming to definitive treatment, splenectomy, indicative of severe HS with transfusion and hemolytic crisis. So remove the spleen, because RBCs have a hard time passing through spleen. So remove the spleen, which is causing all these features in the first place. Performed after first 6 years of age to reduce the risk of infection. The baby is very delicate, so it's fine if it has the spleen, but the adults, if you want to reduce complications, better to remove the spleen. That is what it is mentioned. And post splenectomy, penicillin prophylaxis to prevent infections. There is immunization required against encapsulated bacteria. There is Haemophilus influenzae, Streptococcus pneumoniae, and this thing, because encapsulated bacteria, there is a specific topic in surgery called as OPSI in the spleen chapter, surgery paper 2, wherein we go in detail about OPSI. This it's related to the post. I forgot what the full form is. It's related to post splenectomy, the infection, opportunistic infections post splenectomy, something like that. Yeah. So that is the key question over there. If you want to go in detail, you can read about it. And management of complications, aplastic crisis requires supportive care and transfusions, and gallstones, cholecystectomy in symptomatic conditions. So these two are the main complications, and we have seen how to manage it. And this brings us to the end. So we bring an end to this particular section on hereditary spherocytosis. Now coming to thalassemia major, which is a very important this topic. What is it? Very important practical question too, practical case. So thalassemia major, also known as Cooley's anemia, is a severe transfusion dependent hemolytic anemia caused by defective beta globin chain synthesis. So it is a quantitative disorder. So earlier I mentioned, when I was mentioning about I mentioned it as a qualitative quantitative, some confusion during RDW discussion. So in this specific case, it is a quantitative this disorder. What is it? Hemoglobin disorder, but there is it was a different way of explaining, so it was little bit confusing, but in this specific case the RDW is less. That is the key takeaway if you are confused about what I am trying to say. But coming back, it is a autosomal recessive condition leading to ineffective erythropoiesis, chronic hemolysis, and severe anemia. So ineffective erythropoiesis because beta globin chain has problems, and chronic hemolysis and severe anemia. The disease manifests in early childhood and requires lifelong transfusions and iron chelation therapy. So, lifelong transfusion, you might have seen thalassemia centers in some hospitals, and that is for the lifelong transfusion aspect of it. Coming to pathophysiology, the fundamental defect in thalassemia major is deficiency of or the absence of beta globin chain. So, excess unpaired alpha globin chains precipitate erythroid precursors, and there is RBC membrane damage. So, the thing is, you have less of beta, so alpha to beta 2. When you have beta, less of beta, the alpha increases, the unpaired alpha chains, and these lead to this thing, cell membrane damage, and because of that there is anemia and intramedullary destruction for erythroid precursors. So, these precursors, which are these alpha, these is the same thing, severe anemia because of improper beta chain, improper hemoglobin that is there. Next, coming to compensatory extramedullary hematopoiesis. So, now the bone marrow over there, the cells are getting destroyed rapidly. So, you need cells from somewhere. So, where are those coming from? From extramedullary hematopoiesis. So, these can include from the liver, spleen, from the bone expansion of bone marrow, and from the skeletal region. So, because of that there is clinical manifestations of these things. So, hepatosplenomegaly is seen, bone marrow expansion is seen, and skeletal deformities, which is mentioned later down. Next, coming to genetic factors, autosomal recessive inheritance. Beta globin chain is located on chromosome 11. So, chromosome 11 is the main one, and autosomal recessive inheritance, 25% of transferring to the offspring, which is generally seen in autosomal recessive conditions. Classifications of thalassemia. There is alpha and beta thalassemia. Alpha is silent carrier and normal RBCs. Alpha trait, mild anemia, hypochromic microcytosis, and hemoglobinous disease, moderate hypochromic anemia, and hydrops fetalis. So, this is not, we are not talking about this actually, but since we have classification, we put it here, but this beta thalassemia is what is more important. So, silent carrier, asymptomatic and normal HB pattern, which is just carrier, meaning on the Punnett square, in case you have only the 1/4 of the chance of transmitting, it follows the Mendelian pattern. So, 1/4 of the chance of the trait being expressed in the child. So, rest of the condition there is in 50% of the times the child is a carrier and the normal HB pattern is seen, but when the trait is expressed, there is elevated HB2. So, HbA2, this is a different hemoglobin which is elevated as a compensated response for decreased other hemoglobin. So, which are so coming to the next one, thalassemia intermedia, where there is moderate anemia and occasional transfusions, and the major one, there is severe anemia with lifelong transfusion dependence. So, let us expand more on this, because I realized it is little bit expand more on this. So, over here it is asymptomatic because this is autosomal recessive condition. So, we do not want this, we want to know HbA2 constituents, that specifically would explain what it is. Alpha to gamma to delta 2, yes, this was the one, alpha to delta 2. So, here there is no beta, right? So, because of this amount increases as a compensatory mechanism. I wanted that actually, I put the entire thing, sorry about that. Then thalassemia intermediate, moderate anemia and occasional transfusion, and when there is severe, where there is nothing, no betas, what happens? Severe anemia, lifelong. This is dependent on, so we know the beta, this thing there, hemoglobin beta is it could be, it is a quantitative, right? So, depending upon how much quantity is absent of the beta chain, you have more worse and worse of anemia, worsened anemia. Next, coming to clinical features, there is hematological symptoms, hepatosplenomegaly, skeletal abnormalities, and iron overload, which is secondary to lots of transfusions. First, severe anemia, 2 to 8 grams per deciliter, pallor, fatigue and exercise intolerance, and irritability and recurrent infections. This is general anemia features. Next, coming to hepatosplenomegaly, massive spleen and liver enlargement due to, so we know in fetus the erythropoiesis can happen in these areas, these places too. So now we get those back, and hypersplenism due to hypersplenism due to RBC destruction because of the erythroid, the cells that are there, they are not even good, which are being produced. Skeletal abnormalities, frontal bossing and chipmunk faces, which means I'll show you the picture, that would be better. Chipmunk faces, so hair on head appearance and all that, because axial skeleton is getting involved for lot of axial bones are getting involved for erythropoiesis. Prominent cheekbones and dental malocclusion, so this is, you have already seen what looks like malocclusion. Next, coming to hair on head appearance, we have already seen that. Now coming to when you give a lot of trans, because it's a quantitative disorder, you want more of good RBCs. When you give that, what happens, the RBCs are given, and when the cells die and the lysis of those cells happens, we know the RBC lifespan 90 to 120, and when those cells die, the recovery of iron happens and a lot of iron is stored. Now you keep storing this iron, where else will you store? The body doesn't have enough place, so it is deposited in the skin, leading to bronze skin. It is deposited in these pancreas and all that. Endocrine dysfunction is seen, and there is diabetes, which is also known as bronze diabetes, hypothyroidism, hypogonadism, all kinds of issues, and cardiac failure because of myocardial deposition of iron in the heart muscles. Coming to investigations, so there is CBC, peripheral blood smear, hemoglobin electrophoresis, iron studies, genetic test, and bone marrow examination. On CBC, microcytic hypochromic anemia, which is seen because of less of hemoglobin in the cells, but in case of iron, less of iron is seen, and low hemoglobin, which is obvious. And next, coming to elevated erythrocyte count, because we have anemia and there is compensation by increasing the reticulocyte count. Next, coming to peripheral blood smear, severe hypochromic microcytosis, target cells, nucleated red blood cells, and basophilic stippling. Hemoglobin electrophoresis, absent or very low HbA, HbA meaning alpha 2 beta 2, HbF alpha 2 gamma 2 is elevated very high, and then HbA2 alpha 2 delta 2, this is also high. That is on electrophoresis. So electrophoresis is something we need to mention in the answers. Next, coming to the iron studies proper, the elevated serum ferritin, because you are giving a lot of iron also, and elevated serum iron, low TIBC. This is just opposite to the iron deficiency anemia section. So a lot of iron, it is being recovered from the cells, and it is stored and it is circulating in the blood, and the capacity to bind more iron is missing, so TIBC is less, and genetic testing confirms the beta globin mutations. Bone marrow examination, erythroid hypoplasia with ineffective erythropoiesis. And what is the management? So blood transfusion, as we have discussed earlier, so regular packed blood cells transfusion to maintain the HB levels at 9 to 10 grams per deciliter prevents growth retardation and extramedullary hematopoiesis and risk of iron overload requiring chelation therapy. And the iron chelation therapy requires to prevent iron overload. So now this becomes a problem. When you have a lot of iron, you need to chelate it. So what are the iron chelators we use? Desferrioxamine, and what is the dose? IV infusion 20 to 50 milligrams per kg per day. Desferrasirox, this oral, that is IV 20 to 40, 20 to 50. Desferrioxamine, desferrasirox, Xerox. Bone marrow transplant, curative treatment for thalassemia major and most effective when performed in childhood with HLA matched sibling. Then splenectomy, it is required in case of hypersplenism, if hypersplenism increases transfusion requirement. So what is it, the cells that are already there, if these are getting broken down very quick, you need to remove the spleen. Then OPSI, it is overwhelming post splenectomy infections. OPSI, not opposition, overwhelming post splenectomy infections, requires lifelong penicillin prophylaxis and immunizations, and pharmacological treatment is hydroxyurea, which is same in this one, what is a sickle cell, 15 to 20 milligrams per day, increases HbF production and reduces transfusion dependency. So we have seen the treatment. Now coming to the complications. So iron overload, we have seen this earlier. Iron deposition in the heart, cardiomyopathy, arrhythmias, in the pancreas, diabetes mellitus, in the liver, cirrhosis and hepatocellular carcinoma, endocrine dysfunction, growth retardation and delayed puberty. This is a direct complication of thalassemia major. So hypogonadism, hypothyroidism, adrenal insufficiency. And there is hypersplenism, excessive RBC destruction worsening anemia. And then splenectomy is required if you don't want the RBCs to die. Then skeletal deformities, as we have seen, extramedullary erythropoiesis and transfusion related. So you keep giving the transfusion, it increases the risk of getting transfusion related infections, and because of that we need vaccination and screening. This psychological and social support has impact, wherein he knows that the child knows that it is a lifelong issue and depression and anxiety is a potential problem. And the future therapies, there is gene therapy to correct beta globin mutations and intrauterine bone marrow transplantation, which is intrauterine, and prevention through antenatal genetic screening. And how to prevent it? Carrier screening, genetic counseling, prenatal diagnosis and antenatal screening of high risk population. And that is how we have ended the thalassemia section. This half an hour more, I think. Let's see if we can finish this. So sickle cell, we are looking at just the clinical features and complications not there. Complications are, see, these are the complications. Crisis, all the crisis. We have some crisis here. First look at the what it is. So it is an autosomal recessive, again autosomal recessive condition, just like thalassemia, unlike autosomal dominant, which is hereditary spherocytosis, caused by substitution of valine for glutamine. So instead of glutamine you have, substitution of valine for glutamine, so you have glutamic acid is gone and valine comes there. This mutation leads to production of abnormal HBS, which polymerizes under low oxygen conditions, causing RBCs to assume sickle shape. These are rigid deformed RBCs leading to vaso-occlusion, hemolysis and end organ damage. So these cells, this is obvious, meaning the sickling doesn't let it clogs the blood vessels, leading to end organ damage. And pathophysiology, sickle RBCs lose their flexibility, making it difficult to pass through microcirculation, causing vaso-occlusion. Repeated sickling and unsickling leads to permanent RBC deformation and premature destruction. And platelet aggregation and endothelial dysfunction contribute to inflammation and vascular injury. Increased hemolysis leads to anemia and hyperbilirubinemia. So, those are sickling, meaning clogging related. So, clogging related is there, and then shape related. Because of repeated changing shapes, it is broken down. Then this one, these form abnormally, these clog it, right, clog the microcirculation. Then what happens? Unnecessary clogging leads to activation of platelets, which can lead to aggregation and endothelial dysfunction and thrombosis and all that. And like eventually these cells are broken down, leading to anemia and the hyperbilirubinemia. What are the clinical features? Painful crisis and multi-organ complications. So, vaso-occlusive crisis, we have already seen it. And what is this thing? Areas: extremities, back, chest and abdomen. Extremities, back, chest, abdomen. Hand foot disease syndrome, dactylitis, painful swelling of hands and feet due to infarction of small bones. So, small bones are affected. Avascular necrosis, bone infarction due to vaso-occlusion of nutrient arteries. So, now we have already seen this is in case of muscles and all that, the nerve endings might be affected, but and over here the painful swelling of hands and this thing, but microcirculation of nutrient arteries, if those are affected, avascular necrosis can happen. And which are the most prone areas? Femoral head. So, this is, I think this is a question in ortho, can go through it in case you want to. And even humerus and tibia can get affected, causes joint pain, limited mobility and risk of osteonecrosis. Abdominal crisis, severe abdominal pain and signs of peritoneal irritation and localized bowel dysfunction due to ischemia. Usually resolves within 3 to 5 days with hydration and supportive care. So, peritoneal and the bowel is affected. Actually, even when I go through this particular section on hemat, it's actually quite little bit of this thing to not completely, it doesn't excite me much, because we have been going through this repeatedly over, and the pathophysiology is the same everywhere. It's the same thing depending upon different organs. So, vaso-occlusive crisis of vaso-occlusion, just need to remember the headings. So, in this particular case it is the lungs, chest pain, cough, tachypnea, hypoxemia, fever and pulmonary infarction and sequestration, can progress to respiratory failure. What are the management this thing? It includes oxygen therapy, hydration, antibiotics and bronchodilators. So, lungs are being affected, so make sure that you give the supportive care. Then when brain is affected, cerebrovascular accidents due to occlusion of cerebral vessels by sickle cells leading to hemiplegia, aphasia, seizures, requires exchange transfusion to prevent recurrence. So, next coming to sequestration crisis. So, brain, we are done with brain, and brain is a stroke like features. Sequestration crisis, sudden trapping of large bloods in the spleen or liver. Large amount of blood is trapped in spleen or liver. Massive splenomegaly with hypovolemic shock. So, blood is stored packed in liver and spleen. Because of that, you have less of blood in the circulation, can be fatal. Aplastic crisis, it is triggered by parvovirus B19, acute onset of severe anemia without reticulocytosis. So, parvovirus B19 comes again and it triggers the aplastic crisis, and it worsens existing conditions actually, parvovirus. So, there is no reticulocytosis because compensatory mechanism which is backed by bone marrow is affected, and it resolves within 7 to 10 days. Chronic hemolysis, persistent anemia and jaundice and gallstone formation and all that, which is generally related to hemolytic anemias, and hemolysis and splenomegaly due to excessive destruction. Other features: priapism, painful erection because the blood vessels of the penis are affected. Then delayed somatic and sexual development, renal involvement, which includes hypostenuria. I think it is this thing. What is it? So what is? I forgot this thing. Yeah, specific gravity is hypostenuria. This one meaning specific gravity and less of that, and nephrotic syndrome. So overall, the concentrating ability of the tubules are affected because the blood vessels that this thing. So first of all, the renal cells, the renal system is hypoxic. Hypoxic meaning in generally about to be hypoxic if something happens. And now when you have sickling and all that and vaso-occlusive features, specifically in the kidney, you are affecting kidneys very badly. Retinal infarcts, epistaxis and retinal hemorrhages. So this is in the upper facial region. And just touching upon the peripheral blood smear, the sickle shaped RBCs obviously, and target cells and Howell Jolly bodies. And we have come to the end of discussion on sickle cell. Next, coming to ITP. ITP, we are discussing clinical features and management, and also little bit about how the pathogenesis is and what the definition is. So ITP is an immune mediator, so it is there in the name, idiopathic thrombocytopenic purpura. So idiopathic is usually immune related. It is characterized by antibody destruction of platelet leading to thrombocytopenia and increased bleeding tendency. So thrombocytopenia, less of platelets, and because of that more of bleeding. It's like opposite. Bleeding time is increased. There are two main classes: acute and chronic, less than 6 months, more than 6 months. Acute is seen in children, chronic is seen in adults. Let's see if we have any table or anything. No, it's in medicine actually. The table about differences, acute and chronic, how the severity and all that, it is there in medicine, you can go through it. But for now, we look at this pathogenesis. So autoantibodies against GP2B3A and immune mediated platelet destruction. Antibody coated platelets are trapped and removed by splenic macrophages. The splenic macrophages are the ones. Bone marrow shows increased megakaryocytes compensating platelet loss. So increased megakaryocytes, and the exact cause of antibody production remains unknown, but it is triggered by, so just like many other rheumatic condition, immune conditions, autoimmune conditions and all that, it is very difficult to exactly point it out. Like at the end, if you can't find anything, you put it under idiopathic rate. Yeah, so that's what. That cause of autoantibody production remains unknown. What are the clinical features? So platelets are reduced. So based on that, you have this thing, different manifestations. So history of recent infections, afebrile. So these things exacerbate afebrile. So acute rate less than 6 months. So acute afebrile presentation. So fever is absent, abrupt onset of bleeding symptoms. So what are the bleeding symptoms? Just like normal thrombocytopenia, purpura, petechiae, ecchymosis. These are larger versions. Epistaxis, bleeding from nosebleeds, oral bleeding, gum bleeding, post-trauma bleeding, menorrhagia, heavy menstrual bleeding. What are the other findings? Hepatosplenomegaly, lymphadenopathy and bony tenderness. No systemic features, symptoms like fever, weight loss, joint pain, and no evidence of systemic illnesses. So isolated of this, exacerbated by recent viral infection, and fever is absent, and no other findings. Coming to investigations, platelet count is less because it's there in the name, it's thrombocytopenia less than 1 lakh, usually less than 30,000. Normal hemoglobin and WBC count because other cell lines are not affected. Megakaryocytes are the main ones, these are increased, but the platelets are less. It's a compensatory mechanism. And peripheral smear, larger than normal platelets, megathrombocytes It's like immature, same like RBCs. In case you have less of less of the end product of RBC or platelets, the younger versions are released into the blood. No cystocytes. Helps to rule out thrombocytopenic purpura. Thrombotic. Thrombosis leads to cystocytes. DIC leads to cystocytes, and RGUHS, we have seen it earlier, also leads to cystocytes. Bone marrow examination, increased megakaryocytes, so compensatory response, and then no abnormal WBCs, dysplasias or blast. But if you find any of these, you look into the neoplastic section, the onco section, and which we have here somewhere down. Childhood malignancy, ALL is given very nicely there. Not routinely required unless atypical features are present. Then your management of acute ITP. So general and based on severity specifically for this one. So general features, so general approach, routine platelet transfusions are avoided because those are getting destroyed. Immune cells, immune antibodies are already there, GP2B3A, it detects it and it kills them. So why would you do it? You would do it only when it is for platelet transfusion under this one. Over here you can see life threatening bleeding. In such condition you give platelet transfusion under steroid cover, that is the one. Otherwise what do you do? For observation supportive care is the one, and avoidance of contact. So you reduce the chances of bleeding, so that is greater than 30K. Less than 30K with bleeding, what do you do? First line treatment is IVIG. This is intravenous immunoglobulin, and this is against against those autoantibodies, 1 gram per kg per day, 1 to 2 days, and alternative anti-D, 50 to 75 milligrams per day for RH positive. And you can also reduce the immune response by prednisolone and dexamethasone. First one is for 2 to 4 weeks, next one is for 4 days, then repeated for 3 weeks, so almost a month in both the conditions. Refractory conditions, second line immunotherapy, that was the first line, IVIG. Second line is we use these drugs. These are also used in other onco conditions, and we can use those also too. Vincristine, cyclophosphamide, azathioprine at the DNA level and cell division level, this work there. And this is CD20, again CD20, and this one is splenectomy for chronic refractory ITP greater than 1 year duration, requires post operative. So when you do splenectomy, right, you require this one to reduce the chances of biopsy. You do the vaccination against these infections, microbes. Life threatening bleeding, so already discussed, high dose of IVIG and steroids. IVIG, which is the first line treatment, and steroids, prednisolone and dexamethasone. Along with that, platelet transfusion and emergency splenectomy if uncontrolled bleeding. And we have come to the end of discussion on acute ITP. Now coming to hemophilia A and B. I think it is mainly hemophilia. No, it is hemophilia. So clinical features and treatment. First we look at the definition. Hemophilia is hereditary clotting. It's a clotting disorder, unlike previous one, which is a bleeding disorder, and deficient in or defective clotting factors leading to prolonged bleeding episodes. So there is A and B. A is factor 8 deficiency, B is factor 9 deficiency. Clinical features. Severity depends on percentage of clotting activity, clotting factor 8 or factor 9. So based on that, like how good it is. So mild is 5 to 40%. So in this particular case, severe bleeding with major trauma or surgery, only in such conditions you see it. But in moderate, that is 1 to 5%. Spontaneous bleeding, severe bleeding with trauma, this thing. So spontaneous, mild spontaneous, that's the thing. So spontaneous, out of nowhere it starts bleeding, but it is mild. But in severe, which is less than 1% factor activity, Spontaneous bleeding, predominantly joints and muscles. Sites of bleeding: hemarthrosis, muscle and soft tissue, muscle/soft tissue hematomas, major bleeding which is post surgery and trauma. So this one, hematological joint bleeding, which is commonly seen almost everywhere, 70 to 80% of the cases. Muscle and soft tissue 10 to 20, and surgery 5 to 10, CNS bleed less than 5. What is the treatment? So you have less of these factors, you give more of these factors, you give extra, supplement these factors. So factor 8, hemophilia A, you give 40 international units per kg on day 1, then 40, reduce it to half, 20 over 2 to 5 days. Next 2 to 5 days. Hemophilia B 60 to 80, then reduce it the maximum 80 to half, 40, then 2 to 4 days. Supportive therapy: desmopressin increases the levels of hemophilia factor 8, because those desmopressin is also given in von Willebrand disease. And what does it do? It increases the amount of this one factor 8. And this one, antifibrinolytics like tranexamic acid prevent the clot breakdown, and fibrinolysis of the clot that is formed. So you want more of clotting to happen, right? Because clotting factors are missing. So this is like supplemental supportive therapy. Cryoprecipitate and fresh frozen plasma used in emergencies. Physiotherapy and joint protection: early treatment of joint bleeds prevents chronic joint disease. Early treatment and judicious physiotherapy to avoid muscle atrophy, because you are pain everywhere, can't walk and all that, and also muscles are getting affected. See, there is that. See, muscles and soft tissue hematomas. So because of all that, better to do this one, physiotherapy. And precautions: avoid IM injection and arterial punctures, avoid NSAIDs. And that is how we come to an end of this particular section. Next, coming to, we have 7 minutes more. We can start with respiratory system. Respiratory system, first we talk about bronchiolitis. Bronchiolitis, very important condition, and the most common microbe that is causing it is respiratory syncytial virus. Parainfluenza is for croup. Is it mentioned here? Yes, croup is also there. We'll discuss about it later down the line. So etiology. So first we look at the definition. It is viral infection of lower respiratory tract, viral. So generally upper respiratory tract, right? But in this particular case, lower respiratory. That is how it becomes important, leading to inflammation, narrowing of bronchioles. Virus affecting bronchioles. Infants and young children under 2 years, characterized by wheezing, respiratory distress and hypoxia. So there is etiology, viral, bacterial, and then we speak about the risk factors. Viral, there is RSV, which is most common, then parainfluenza, influenza, adeno, metapneumo, and Boca virus. Next, coming to bacterial causes: Mycoplasma pneumonia, which is rare, because this is generally the definition includes the viral of the bronchioles. This comes, I think, you put it on the pneumonia, like pneumonia along with bronchioles and all that, it might get affected or something. But over here, for completion's sake, Mycoplasma pneumonia, Haemophilus influenza can cause secondary infections. What are the risk factors? Pre-existing lung condition, bronchopulmonary dysplasia, chronic lung disease, formula fed infants. So we have seen how important the breast milk is for the immune functioning for good immune functioning. So formula fed, it is bad. Maternal smoking and household overcrowding, and because of increased risk of infection, infants with smaller airway size, diminished lung function, and depending upon the seasons, winter and spring. Next, coming to pathophysiology. So what happens? Viral infection of bronchiolar epithelium. So bronchioles, so if you remember, bronchioles in lungs. So bronchioles, there is trachea, there is bronchus, and at the end, just before alveoli, there are bronchioles. So pneumonia is usually here, but bronchioles is somewhat closer to location wise. So bronchiolitis, bronchioles, inflammation of that, bronchiolitis. So inflammation and necrosis of bronchiolar epithelium, and then with that you have edema, mucus production, cellular debris causing airway obstruction, bronchiolar narrowing and spasm, increased airway resistance and work of breathing, and ventilation perfusion mismatch leading to hypoxia and carbon dioxide retention. So these are the subsequent steps. Then over at the end, atelectasis, which is lung collapse, alveolar collapse and air trapping due to partial airway obstruction. So it's like mainly the edema, that is mainly due to epithelium getting affected, then subsequent edema, mucus production, cellular debris which cause more of airway obstruction, and there is spasm and narrowing more, and overall there is retention of carbon dioxide, there is hypoxia and eventually atelectasis. Clinical features. So initial symptoms, progressive symptoms, then there are complications of respiratory distress, and we have examination findings. Coming to clinical features, low grade fever, viral infection, coryza, nasal congestion, mild cough. This is like general viral symptoms. Then progressive, now you go down into the bronchioles, fast breathing, decreased oral intake, so you don't want to eat food, irritability and dyspnea and cyanosis, apnea more common in infants less than 6 months, apnea more common in infants less than 6 months, and signs of respiratory distress, tachypnea, use of accessory muscles and nasal flaring, and tracheal tugging. Auscultation findings, fine crackles and wheezing. We'll finish this off properly. Tachypnea means increased this thing, you can't get enough of air, hypoxic condition and backing up of carbon dioxide, and then you want to release more, so use accessory muscles and nasal flaring and tracheal tugging. Auscultation findings, fine crackles and wheezing, prolonged expiratory phase, so inspiration, expiration, and which is longer? Inspiration is longer, but both are equal, right? I cannot forget, it's important. Inspiration, expiration, phase length, I think both should be equal. Yeah, inspiration is shorter, expiration is longer. Fine. It's fine, we are here to learn. Prolonged expiratory phase, like a lot of expiration because trapping is happening, air trapping, reduced breath sounds in severe conditions, airway obstruction, it acts like an obstructive disease, looks like it, and severe cases there is silent chest, marked airway obstruction with reduced wheezing and respiratory failure. Differential diagnosis, foreign body aspiration, gastroesophageal reflux disease and other things like airway anomalies. Differential diagnosis. So coming back, initial symptoms like simple viral symptoms, then when you go progressive, when worsening happens, then respiratory distress and auscultation findings. In severe cases there is marked airway obstruction and respiratory failure. Coming to diagnosis, clinical diagnosis is the primary method based on the history and examination, no need of blood test or viral culture. Pulse oximetry detects oxygen, this thing, and chest x-ray is not required, but when you do it, there is hyperinflation suggesting airway obstruction and Tachi infiltrates, atelectasis, which is collapse, and reticulonodular pattern. Let's check this out. Bronchiolitis X-ray. So nodular, is this the one? Nodular, this thing. Okay, fine, no problem. Let's see how many this thing we have. I think we can finish the management. Let's finish the management and take a break. Close this. Yeah. So reticulonodular, reticular meaning network like. And blood tests not required unless bacterial this thing is detected. Management, supportive therapy, humidified oxygen therapy to reduce the instance of hypoxia. Frequent nasal suctioning to relieve upper airway obstruction. So whatever nasal suctioning, upper region should be cleared off. Maintenance of IV fluids for infants with poor feeding. So in case concomitant, like simultaneously when you have this problem, you eat less because of that IV fluids. Medication, nebulized hypertonic saline helps clear mucus. So this one is a mucolytic hypertonic saline. Racemic epinephrine nebulization, severe cases like there is constriction, spasm and all that, you want to open it up. Bronchodilator, same thing, to open it up, the airway. And corticosteroids, not usually, but because the mechanism for corticosteroids to open up that is much different. It is to reduce inflammation and all that, like it could be useful, but here it is not used. Antiviral therapy, ribavirin, aerosolized form in severe conditions, used in case of congenital heart disease, chronic lung disease and immunocompromised patients. Indication for hospitalization, respiratory distress, you have already seen the clinical features. Let's see them again. Tachypnea, use of accessory muscle, nasal flaring, and this thing, what is here? Yeah, apnea, severe hypoxia, doesn't feed properly, and comorbidities, other conditions. So overall, for these things we look for hospitalization. So management we have seen, supportive care, specific medications. And since it's a viral thing, we give antiviral, but only in these conditions. And complications, respiratory failure, secondary bacterial infection, dehydration, malnutrition, and long-term complications. So severe obstruction, obstruction, right? Obstructive this thing, and there is no this thing breathing that is happening, and there is apnea and respiratory arrest. So you give continuous positive, so positive airway pressure, mechanical ventilation, so that it keeps going, the breathing keeps happening. Secondary bacterial infection, bacterial pneumonia due to mycoplasma and streptococcus pneumonia, the otitis media. Otitis media generally ears and nose connected through that eustachian, and because of that there could be otitis media. Dehydration, malnutrition, that is this thing, and long term complications are also seen, like recurrent wheezing, asthma, and later in childhood. Prognosis and outcome, this is high risk of respiratory failure within 48 to 72 hours. Overall prognosis is good, case fatality rate less than 1%, death occurs due to the complications, and RSV immunoglobulin in high risk infants, and pavlizumab specifically to prevent RSV in these particular conditions, preterm infants, congenital heart disease. And that is how we have come to the end of acute bronchiolitis, and now I shall take a break and get back to you after the break. Until then, when you can take a break. So I turn off the camera and the voice. Welcome back. So let's continue. So right now we are in epiglottitis. So epiglottitis, key organism Haemophilus influenzae type B, HIP. Life-threatening upper airway obstruction, caused by inflammation and edema of epiglottis, like it comes from the name itself, and surrounding structures, leading to acute respiratory distress, rapidly progressive, and can result in complete airway obstruction and death if not managed promptly. So it's very much important emergency and affects and in ENT as well as in pediatrics, children aged 2 to 6 years. So, but it is rare in vaccinated population. So what are the coming to etiology specific? There are multiple, but the most common one is influenza B, Haemophilus influenzae B. And what are the others? Streptococcus pyogenes. And is this the same one that causes scarlet fever? Yeah, I think it is. Streptococcus pneumoniae and Staph aureus. And next one, coming to non-infectious causes like thermal injury, ingestion of very hot liquids, and caustic. These are physical things that can cause epiglottitis: thermal injury and caustic ingestion. Coming to pathophysiology, bacterial invasion of epiglottis leads to inflammation and swelling, edema and airway narrowing. It leads to these things like bacterial invasion of epiglottis. Invasion of epiglottis leads to inflammation and swelling of that particular structure, and there is edema and airway narrowing rapidly, and they rapidly progress to complete obstruction. So it's a small space there, and if there is edema of that particular structure, it is completely blocked, and respiratory failure and asphyxiation can occur if it is not treated early. Clinical features. So there are early symptoms and 3 Ds, and there are some signs. So first we look at the general symptoms, early symptoms: high fever, sore throat and difficulty swallowing, dysphagia, and rapidly progressive respiratory distress. So what happens? 3 things: dysphagia, difficulty swallowing, that is drooling saliva; dysphonia, muffled voice is affected because that comes near the larynx; and dyspnea, that is respiratory distress, wherein you see stridor and retractions. What are the characteristic signs? So 3 Ds we are done: dyspnea, dysphagia and dysphonia. Characteristic signs: child hyperextends the neck to maintain airway, assumes tripod position, sitting upright, leaning forward with chin up and mouth down. Tripod position epiglottitis, we need to look this up. Epiglottitis, yes. So you can see the child is sitting in a tripod position. Look at how the hands are, how the face is, where the mouth is, what the angulation is, and extension of the neck. Yeah. Severe hypoxia and restlessness, cyanosis and coma in advanced conditions. Stridor, a late and ominous sign of near total airway obstruction. Diagnosis. Clinical diagnosis based on classic symptoms of 3 Ds and avoiding anxiety provoking examination as it can worsen obstruction. Direct laryngoscopy. Visual examination of cherry red swollen, I'll take this off later, sorry. Cherry red swollen epiglottitis. If you want, I can show it to you here. Cherry red swollen epiglottis, like classical signs of inflammation, should be performed only in control setting, that is operating table. So laryngoscopy only on the upper interval. And what do you see? Cherry red, swollen epiglottis. Imaging, lateral neck X-ray reveals thumb sign, enlarged epiglottis. Thumb sign you can see over here, this arrow mark. This is enlarged epiglottis. Hyperextension of the neck is needed for proper visualization. Hyperextension of neck like this. And laboratory tests, blood cultures, epiglottic surface cultures. What is the management? Airway management, supportive care, antibiotic therapy, and post-exposure prophylaxis. Airway management, immediate hospitalization in ICU, immediate, avoid oral examination or unnecessary stimulation. Anxiety can worsen it. Emergency nasotracheal intubation, nasotracheal or tracheostomy. Supportive care, humidified oxygen therapy because it is blocked and we don't want hypoxia, and intravenous fluids to maintain hydration because overall it's an infection. Antibiotic therapy because it's an infection, Haemophilus influenzae. Ampicillin, chloramphenicol, one is 100 milligrams kg per day, other one is 50, half of that, 150. Ampicillin, chloramphenicol. Alternatives are cephalosporins and meropenem. Post-exposure prophylaxis includes rifampicin, 20 milligram kg per day for 4 days, and for household contacts, if child is less than 4 years, is completely immunized. Infant less than 12 years or 12 months and not completed hip vaccination, so mainly not vaccinated. An immunocompromised person in the household. So in these particular conditions, you give them prophylaxis, which is rifampicin 20 milligrams kg per day. And what is the treatment? Ampicillin 100 milligrams kg per day, chloramphenicol 50 milligrams kg per day, half of this. And alternates being cephalosporins and meropenem. Complications like worsening of respiratory distress, pulmonary edema, there could be pneumonia, cervical lymphadenitis because it is a bacterial infection, can go to lymph nodes and all that, and this thing is connected, what is it, the eustachian tube being connected to this one, and then there is meningitis, septic arthritis. And that is how we have come to the end of epiglottitis. Next, coming to pneumonia. Pneumonia, it's a very big thing, very big chapter, very big section, and we have the definition, classification, etiology, clinical features. It is lagging. Investigations and treatment, and finally we have complications. So let's do it one by one. So definition: pneumonia is an acute inflammatory condition of lung parenchyma. So lung parenchyma is affected. Earlier what we saw in case of epiglottitis, the bronchiolitis, the bronchioles, that is not the that is the airway. Here it is lung parenchyma causing leading to from bacterial, viral and fungal infection, leading to consolidation, alveolar filling with exudates, not transudates, exudates, both are different, exudate and impaired gas exchange. Viruses are more common in younger children, while bacteria is more common in older children. Term pneumonitis is used when the cause is non-infectious. Classification: so it could be both based on the mode of acquisition and based on radiological findings. Mode of acquisition: CAP, this one community acquired and nosocomial. So community acquired, we'll see that first. And which one is this? This is not general pneumonia, but in medicine it is community acquired pneumonia specific. And also there should be, I'm not sure, is there a specific hospital like nosocomial was also asked. If it is not there, I'll just add it. I remember about it just now. Yeah, acquired outside hospitals in previously healthy children. Previously healthy, no hospitalization within 14 days prior to symptom onset. And nosocomial develops after 48 hours of hospital admission. And there is special nosocomial type which is ventilator associated, occurs greater than 48 to 72 hours after endotracheal intubation. Based on radiological findings, there is lobar pneumonia, bronchopneumonia, interstitial pneumonia. Lobar pneumonia involves one lobe. So this is radio. You see on scans, one lobe or entire lung. Bronchopneumonia, bronchus and all that, patchy consolidation and all that. So this thing, what is that I mentioned earlier, like bronchiolitis? It's like it could be a part of this if you actually think about it. Anyways, and even since the definition mentions in younger children, viruses are more common. Like the definition of, maybe it's a sub way of looking at the infections, like proper sub classification of infection of lungs. Anyways, we'll continue on this. Then later on we can just clarify the understanding. But if someone comes up and just looks at the timestamp, just goes to that and doesn't look at other sections, then maybe depends. If he just sticks to what is written here, it is well and good. But discussions happen so that speaking happens so that better understanding can take place from this on this side, meaning the host side, as well as the listener, because even I am not an expert. I have exams coming up. Etiology. We didn't finish it. Interstitial pneumonia, supporting structure connective tissue between alveoli. So these have separate kind of organisms that cause it. So based on etiology, based on this one, or based on age. So age group, there is 0 to 3 months to 5 years, and greater than 5 years. First we look at youngest age group, what it is, what causes. Gram negative, Enterobacteriaceae, Enterococci, Chlamydia, group B, Streptococcus, Haemophilus influenza, Streptococcus pneumoniae, Listeria, monocytogenes. Need to remember this somehow. 3 months to 5 years, viruses are the most common, and all this RSV, adeno, influenza, parainfluenza, human metapneumo, bacterial Streptococcus pneumoniae, Staph aureus, Mycoplasma pneumoniae, and all this. So okay, so this makes sense. Somewhat contradicts the previous discussion that we had on this thing. What is it? Which one was it? This thing, first topic, the first topic. It's fine. Anyways, coming back, greater than 5 years, Streptococcus pneumoniae, Mycoplasma pneumoniae, Staph aureus, and viruses. So these so strep pneumoniae, which is like in adult types also, it is very common. Mycoplasma pneumoniae, Staph aureus, and viruses. So need to remember these somehow. Entero, Chlamydia, group B, Streptococcus, Haemophilus influenza, strep pneumoniae comes here, and Listeria, monocytogenes. And here there are so many viruses. Then comes all those Streptococcus pneumoniae, Staph, Myco, and Hib, Haemophilus influenza. Next, coming to risk factors. So prematurity and low birth weight, like immune function is compromised. Malnutrition, vitamin E deficiency, immune functions gone again, and low breastfeeding, lack of breastfeeding, immune function again, loss of maternal antibodies, passive smoking. In this particular lung innate way of defense, I think that is impaired. Ciliary clearance and all that, probably there is some kind of mucus overload, I feel, because of increased smoking, and overcrowding and poor socioeconomic status because of increased risk of transmission, and family history of bronchitis and asthma is predisposing factors. Clinical features, so symptoms and signs. Symptoms: fever, cough, rapid and difficult breathing, which is like an expected case of pneumonia. Lethargy, poor feeding, vomiting, irritability, and cyanosis. These are secondary, meaning like in the main this issue is here, but rest of it, like, it comes up. And then chest, abdominal, neck pain in some conditions. Then signs, what the doctor sees: sick looking child, tachypnea, nasal flaring, intercostal retractions. Decreased oxygen saturation may be noticed, SpO2 is reduced, and expiratory, coarse crackles affecting over the affected lung. Coarse expiratory crackles, end inspiratory coarse crackles, and inspiratory coarse crackles. Classical signs of consolidation include dullness on percussion, decreased breath sounds, and bronchial breathing. WHO grading. So there is pneumonia, severe pneumonia, very severe pneumonia. So pneumonia normal, less the fever, we look at fever less than 38.5 degrees Celsius, no feeding difficult, no dehydration, cough and tachypnea. But in case of this, there is severe, there is fever is very high, greater than 39, difficulty in feeding, tachypnea, grunting, intercostal retraction, dehydration, bronchial breath sounds. But lower down it is inability to feed, altered sensorium, intermittent apneic spells, cyanosis, excessive diaphoresis, acidosis, SpO2 less than 92. It's very critical condition. So what does this stop at? This one, bronchial breath sounds. Over here it is acidosis, SpO2 and all that. Intermittent apneic spells, cyanosis, excessive diaphoresis. Next, coming to investigations. There are these blood tests. So investigation, blood tests, and then radiological investigations and microbiological tests. Blood tests, complete blood count with leukocytosis with neutrophilic predominance, neutrophilia, and lymphocytosis in viral pneumonia. Then C-reactive, CRP, are increased because inflammatory state. Radiological, X-ray. So because of X-ray we were able to classify the different types of pneumonia, and here we have lobar consolidation, patchy infiltrates and pneumatoceles. And now we go to ultrasound chest. It can identify pleural effusion and empyema pus in pleural cavity. Pneumococcal pneumonia is lobar, and viral and mycoplasma is patchy infiltrates and pneumatoceles staph pneumonia. Microbiological tests, sputum examination, sputum culture we can detect, and nasopharyngeal swab for viral infection. So given in COVID we can add this. Management, general supportive care, oxygen therapy if SpO2 less than 92, IV fluids and rehydration, antipyretics for fever, and nebulized bronchodilators is if wheezing is present. So wheezing means narrowing up the airway, right? So if you want to dilate the airway, what do? You go bronchodilators. But in the previous case, what else did you give? There was complete spasm and all. Epinephrine also, yes, epinephrine. And second one, what is this? Antibiotic therapy, yes. Outpatient management. Actually, this is nice way of teaching, like slight diversion, nice way of learning things, because it comes out through my mouth, and I might remember this for a long period of time. Otherwise, it is just me repeating it in my head. Like it requires a lot of energy, right? The way you explain things and all that. So it is very helpful even for the host. Yeah, host factors. Sorry, outpatient management. First line, oral antibiotics, 5 to 7 days. 3 months to 5 years is amoxicillin. Greater than 5 years, amoxicillin macrolides if mycoplasma is suspected. So first line is amoxicillin for 3 months to 5 years, and greater than 5 years amox or macrolides. So macrolides, as you all know, it's like for atypicals and all of that, and this one is an atypical. Because why? Because it doesn't have a cell wall, and amoxicillin acts only on the cell wall of bacteria. Second line therapy, co-amoxiclav, amoxicillin plus clavulanic acid, and cephalosporin, this is cefuroxime, chloramphenicol and macrolides. So better to remember this one, what is it, antibiotic names. So cell wall affecting that, there is no cell wall, you give macrolides. And second line is co-amoxiclav, cefuroxime, It's like additionally clav. What is that? Beta lactamase. That one, yeah, beta lactamase inhibitors. I think that is the one. Beta lactamase inhibitors. Yeah, beta lactamase inhibitor, clavulanic acid. So it is accompanied with that to inhibit the beta lactamase of the bacteria that can cause that is potentially resistant to normal amoxicillin, then cefuroxime, and then chloramphenicol and all that. Yes. Inpatient management. This was outpatient. Okay, outpatient in OPDs. Inpatient meaning you bring them into the hospital and let them stay. Indications for hospitalization: hypoxia, respiratory distress, poor feeding, immunocompromised status. IV antibiotics 5 to 7 days, then switch to oral if stable. So 5 to 7 days IV, then oral. 5 to 7 days IV, then oral. Then less than 3 months, greater than 3 to 5 years, and greater than 5 years. So less than 3 months. This was not there previously, but here we added cefotaxime, ceftriaxone plus or minus aminoglycosides. Cefotaxime, ceftriaxone, aminoglycosides. 3 to 5 years. Second line therapy, which was here, coamoxiclav, ampicillin, chloramphenicol. So these two from here. And greater than 5 years, ampicillin to come down, macrolides if mycoplasma. So mycoplasma, there is macrolides. Complications: pleural effusion, empyema. It requires intercostal drainage. Pneumothorax, pyo meaning pus, pneumothorax and lung abscess could happen, could take place, and respiratory failure and sepsis and metastatic infections. And we have come to the end of pneumonia. Let's see how much do we have. Then the CVS is a big section, then after that then CNS comes up. Kidney is also important, but less number of questions. Let's see. So ARI control program, this is actually, it is a very, let's see how much I can go through, because this is in one of the 10 markers. This was asked as add a note on ARI. So let's see. Acute ARI includes various kinds of infection that cause inflammation of respiratory tract, nose to alveoli, and it is a leading cause of morbidity, mortality in worldwide, especially in low income countries. So epidemiology classification, I doubt we need it, but they classified, that is important. Upper respiratory, lower respiratory. So we have common cold, pharyngitis, tonsillitis for upper, and pneumonia, bronchitis, bronchiolitis for lower. Then ARI control program in India, which is what this answer is all about. There is in 1990 it was launched, 1992 integrated into CSSM, which is this Child Survival and Safe Motherhood. 1997 included under RCH, now part of IMNCI, and it is used to train healthcare workers to diagnose and treat ARI at community level. What is the protocol? There are 3 steps: case finding the case and assessing the case, then case classification, then we have management. So primary signs, so case finding, so a patient comes up with cough and difficulty breathing under 5 years. So then what do you do? Then then you classify the case, that is the step 2. So child classified under 2 age groups: infant less than 2 months, greater than 2 months, that 2 months to 5 years. If it is less than 2 months, pneumonia diagnosed if respiratory rate greater than 60 with clinical signs. All cases require hospitalization and IV antibiotics. Minimum antibiotic duration is 10 days, and preferred are these: ampicillin, gentamicin. So based on the age group, there are different signs, clinical signs, and based on that we have classification. So no pneumonia, we'll see that first. Home care and counseling, so that is what this thing is. What is it? Cough, cold and no distress. Wait a second. Requires urgent referral. Yeah, there is some issue with this table. I'll just get back to it later. I'll just update it. So basically classification. So based on this, based on whether there is no pneumonia, severe pneumonia, and all of that, you have different what do you say, different treatments. So that is what mentioned over here. Less than 2 months, very severe disease, less than 2 months requires urgent referral, warmth, start antibiotics. Severe pneumonia, urgent referral. This one same thing, I guess, same thing repeats up this one also. So severe respiratory distress, cyanosis, fast breathing, chest throbbing, and no pneumonia means cough and no distress. So in that particular case, you do home care, and you for this thing urgent referral in case of severe pneumonia, and urgent referral same thing for very severe pneumonia, and very severe less than 2 months, 2 months to 5 years. Urgent referral, maintain warmth and start antibiotics. Severe pneumonia, urgent referral, keep warmth, start first dose of antibiotics. No pneumonia, home care and dangers and counseling. Children 2 months to 5 years. Very severe pneumonia, same thing. Severe pneumonia, here it is oral antibiotics and supportive care. No pneumonia, home care and symptom review and monitor. So what is the definition of fast breathing? So definition is infants less than 2 months. For infants less than 2 months, it is respiratory rate greater than 60 beats per minute. So here fast breathing is over here, starts from severe pneumonia. So less than 2 months, greater than 60, and greater 2 months to 1 year, it is greater than 50, and 1 year to 5 years, it's greater than 40. And the finally, sorry, step 3 was here actually. Step 3, it is appropriate antibiotic therapy. So 60 to 100, so cotrimoxazole 60 to 10 milligrams kg per day, chloramphenicol 25 milligrams kg per day for 6 to 8 hours, 8 hours, amoxicillin 20 to 30 in 3 divided doses. So naming, I feel unless it's this is not a very important one, but in case you want to, you can know the doses. But in general, these are the drugs: cotrimoxazole, chloramphenicol, amoxicillin. Prevention, same thing, immune status and all that, maintaining that, better maternal and child health, improving sanitation, clean water access, and reducing indoor air pollution. Socioeconomic development due to reduce malnutrition. And this is this thing is done. And foreign body aspiration, this is somewhat important, because this can come up in the normal OPD. So foreign body aspiration, it's a common pediatric emergency in infants and toddlers due to their tendency to put objects in their mouths. It causes partial or complete airway obstruction, leading to respiratory distress, choking, and potential death. And if not managed promptly. So in management, first investigations, chest X-ray is number 1, first line imaging therapy, radiopaque foreign bodies visible on chest X-ray, expiratory films and lateral decubitus weaves help detect air trapping. Sorry about that, cannot show it to you. I'll show it here. Yeah, so where can we see? Yeah, so here you can see one of the sides, there is the size of this thing is lot more than this side. So that is on expiration. That means it is blocked. The pathway is blocked over here somewhere. That is foreign body aspiration. Lobar emphysema, bronchiectasis, pneumonia may appear in chronic cases. So in case acute conditions, it stays there, becomes chronic and can cause other things. Lobar emphysema, bronchiectasis, pneumonia. Lobar emphysema, bronchiectasis, pneumonia. Fluoroscopy, more sensitive than chest X-ray, used for plain radio when plain radiograph is inconclusive. Shows mediastinal shift during inspiration. So fluoroscopy is another investigation modality and it is more sensitive. And mediastinal shift, this is somewhat even in tension pneumothorax and all that, right? We have seen mediastinal shift even in this particular case seems to be happening, which can be detected on fluoroscopy. CT scan, contrast with is contrast with contrast CT with contrast is used for suspected chronic FBA. Detects small or non-radio opaque foreign bodies. Then there is ventilation perfusion scan, detects ventilation defects in affected lung, ventilation defects, helps in chronic cases where other imaging is inconclusive. So, ventilation perfusion scan. Then there is bronchoscopy, gold standard for diagnosing and removing foreign bodies, allows direct visualization of the airway. So, we need to look at how this looks like. Yeah, bronchoscopy and direct visualization. So, you can see something was stuck here and they have successfully managed. Looks like some kind of seed or something, seed or nut. Anyways, that is the investigation. So, first one chest x-ray, number 1. Number 2 fluoroscopy, this gives the site and all that, can give because of opacity. Fluoroscopy can show this one, what is it, mediastinal shift and all, and it's more sensitive. CT scan detects small and radiopaque foreign bodies, and ventilation perfusion where other images are not working. So, this is at base level, what is the alveolar level. Bronchoscopy, you have seen the imaging, how it looks like. Treatment of foreign body aspiration. So, we have emergency management, airway management, definitive removal and surgical removal. Emergency management, if foreign body is visible in the mouth, remove it carefully, avoid blind finger like this to prevent pushing of the foreign body deeper, encourage coughing in conscious child, and if choking is present less than 1 year, 5 back blows followed by chest thrust. Back blows followed by chest thrust, and children greater than 1 year, that was for less than 1 year, greater than 1 year, Heimlich maneuver, which is which we all know how to do. Next, coming to airway management. So, that was emergency. The above measures fail, perform emergency. So, emergency management meaning immediately, but this is in detail what specific things need to be done. Urgent cricothyrotomy, then tracheostomy, or and then endotracheal intubation with smaller tube. So, these are for airway management: urgent cricothyrotomy, tracheostomy and endotracheal intubation. Removal of foreign body. So, you can either use rigid bronchoscope or flexible bronchoscope. Rigid is more preferred for airway, for foreign body removal, allows direct retrieval. This is for distal airways. So, let us look how the flexible versus rigid by bronchoscopy. You can see how those look like. We have already seen these in ENT, but once again to refresh the memory, how those look like. This is for distal and this is for proximal easy removal. Next, coming to surgical removal, thoracotomy or lobectomy. If bronchoscopy fails, it is invasive, proper invasive surgical procedure. And then finally we have supportive treatment, antibiotics, steroids, treatment of secondary complications. Antibiotics for secondary bacterial infection like pneumonia, steroids for inflammation, not inflation. Inflation is somewhere else. Treatment of secondary complications like atelectasis, empyema and bronchiectasis. So this on long standing cases, and this thing can occur, secondary bacterial infection, and immediately we can also see atelectasis and all that. So remembering whatever the extra things related to foreign body, not just the acute condition what can possibly happen, even the chronic condition can help us to write a very good answer. Coming to bronchiectasis, so it is a very short section because bronchiectasis is more of an adult problem rather than a pediatric, but it is a pediatric problem too, we should never forget that. So what is the etiology? So this is a 3 marker over here. Bronchiectasis is a chronic suppurative disease carried by irreversible dilation and distortion of bronchial tree. Dilation and distortion of bronchial tree leading to persistent inflammation, mucus accumulation, and recurrent infections. Persistent inflammation, mucus accumulation, and recurrent infections. Inflammation meaning inflammation of this thing, mucus accumulation. So we have seen this previously also, again in bronchiolitis, something similar, but overall bronchial tree. And here there is dilation. There it was spasm and all that, a complete closed thing. And but inflammation is there in both, mucus accumulation there in both, and here there is specific feature which is recurrent infections. And causes include post-infectious causes, congenital causes, foreign body aspiration, congenital syndromes. First we look at the infectious: pertussis, measles, TB, pneumonia. Congenital includes cystic fibrosis, cartaginous syndrome, and immune deficiency syndromes. Cystic fibrosis, we all know the chloride channel which is affected, and because of that multiple things can occur, and one of the things include repeated respiratory tract infections, bronchiectasis being the most important one. And then primary ciliary dyskinesia, cartaginous, impaired dynamo of the cilia, and because of that mucociliary clearance is affected. Immunodeficiency, hypogammaglobulinemia, where it is immune functioning is not working properly. Foreign body aspiration, retained foreign bodies can cause local obstruction leading to chronic inflammation and bronchial wall damage. And then there is different syndromes. Absence of annular bronchial cartilage. So bronchial cartilage, it is absent in Williams-Campbell syndrome. And congenital tracheobronchomegaly, megaly, bigger size, it is in Magnier-Kuhn syndrome, Magnier-Kuhn syndrome. And congenital extrinsic compression of middle lobe bronchus by hilar lymph nodes, right middle lobe syndrome. So these are some of the congenital conditions. One is Williams-Campbell syndrome, where cartilage is affected. Magnier-Kuhn syndrome, where congenital tracheobronchomegaly. Right middle lobe syndrome, where chronic extrinsic compression of right middle lobe is seen. And this is the discussion on etiology of bronchiectasis. Then there is, I think this is a 5 marker. Yes, it is. So the next one, which one is croup? We have 10 minutes remaining. Let's see how far we can reach. Croup is acute laryngotracheobronchitis, very long name. Larynx, trachea, and bronchus. So croup is most common cause of stridor in children, acute viral infection affecting glottis and subglottic, below glottis. It causes airway narrowing, resulting barking cough, hoarseness, and inspiratory stridor. Barking cough, hoarseness, and inspiratory stridor. Most commonly affects children 3 months to 5 years with peak at 2 years. So 3 months to 5 years with peak at 2 years. Most frequent in winter months. So just like the other things, seasonal variations and sporadic cases throughout the year. And etiology, viral causes most common. There is parainfluenza type 1, 2, 3, influenza A and B. It's like viral, right? So it's a viral thing causing this issue. And parainfluenza, the number 1. Influenza A and B, adeno, respiratory syncytial virus, RSV, and measles. So some are like by looking at so many all these etiology, we shouldn't forget that which one is the most common. In this particular case, parainfluenza. Similarly, previously we discussed on pneumonia and all that. We classified based on age, what is the most common etiology is, and all that. And even in that case, the top one should never be forgotten. Very important. Influenza, adeno, respiratory syncytial, and measles. Coming to pathogenesis, viral infection of nasopharyngeal epithelium spreads to the larynx and trachea. Larynx and trachea. Inflammation of subglottic leads to mucosal edema, ciliary dysfunction, and airway obstruction. Mucosal edema, ciliary dysfunction, we have seen, could be due to many things. Airway obstruction. And subglottic region is narrowest part of the infant's airway, making inflammation highly obstructive. And increased airway resistance leads to stridor, cough, and respiratory distress, which are the clinical features. Yes, so main thing to remember is the site, larynx, trachea, and then airway nerving being the most important pathology leading to these things. Etiology, viral causes. I went up there. Yeah, clinical features. And then so what was it? Because nasopharyngeal epithelium is affected because of viral infection, and subglottic region, yes, and which leads to mucosal edema and all that, and obstruction, airway obstruction, and subglottic region being affected in children, which is narrowest part, leading to clinical features. So what are the clinical features? Early symptoms: subacute onset of fever, cough, sore throat, rhinorrhea. Symptoms can worsen over 2 to 3 days. Characteristic symptoms: barking cough, which is seal like, hoarseness and inspiratory stridor, and symptoms worse at night. So hoarseness and inspiratory stridor, barking cough, symptoms worse at night. Severe cases, so these like most common: barking cough, seal like, and then severe cases: tachypnea, suprasternal intercostal retraction, continuous stridor, hypoxia, cyanosis, and then there is an altered sensorium, hypotonia. Then diagnosis, investigations. Classic symptoms as mentioned earlier for clinical diagnosis are barking cough, stridor, hoarseness, important for laryngotracheobronchitis or croup. Radiological features: steeple sign, so you can see steeple sign indicates laryngeal edema. Absence of steeple sign does not rule out croup. And laboratory tests not routinely leukocytosis in bacterial superinfection. And differential diagnosis: this affects the similar region, right? So epiglottitis, bacterial tracheitis, foreign body aspiration, angioedema, because it's the same thing, like struggling to breathe. Angioedema, struggling to breathe. Retropharyngeal abscess, same thing. Similar clinical features. Coming to management, meaning treatment, supportive care is the mainstay of treatment. For croup, it's a viral infection, right? Hospitalization, severe case, hydration and oxygen therapy, and keep the child calm, because this is just like other things. If you agitate, there is worsening of airway obstruction. Medications: so once again we have epinephrine. So what is the dose? 0.25 to 0.5 ml in this particular percent of normal saline. I'll just remember it as epinephrine in normal saline. Nebulized racemic epinephrine with normal saline reduces airway swelling, short term benefit can last up to 2 hours. And corticosteroids, there is dexamethasone, reduces inflammation symptoms, and nebulized budesonide. There is Heliox, helium oxygen mixture, used in severe cases requiring intubation. So Supportive care, there are certain medications, epinephrine and corticosteroids, and several cases like Helios require this, and other modality includes Heliox, helium oxygen mixture, and airway management for impending respiratory failure. Then there is prognosis and outcome, which is not really important in case of exams. But complications include these: middle ear infection, bacterial tracheitis, pneumonia. And we have come to the end of discussion on this. Now we are going to bronchial asthma, very important chapter. Let's see how much time do we have. 5 minutes, and this is actually a 10 marker, and it is not possible to finish all of this, but anyways it is worth trying. What is the definition? Bronchial asthma is a chronic inflammatory, it is chronic, not acute, inflammatory airway disease characterized by episodic airflow obstruction, episodic, which is reversible. Episodic airflow obstruction is either spontaneously or with treatment. One of the most common causes, chronic causes of childhood, and leading cause of common chronic diseases of the childhood and leading cause of morbidity. More than 80% of the cases present within 5 years of age. 5 years. So main characteristic features, pathologic features: airway inflammation, airway obstruction due to bronchospasm, mucosal edema, and mucus stagnation. Airway inflammation, airway obstruction, airway hyperreactivity to aeroallergens and irritants, airway remodeling in uncontrolled asthma. And then what are the predisposing factors? Host factors. So host factors include genetic and other factors. Then the environmental factors, allergen, seasonality. So it's mainly asthma, can put it under allergy like interchangeably, and then there is seasonality to tobacco, air pollution, food allergens, pets. So this one, coming back, we'll go in detail. Genetic, more than 100 genetic loci are linked to atopy, which is allergic tendency. Most commonly associated pro-allergic, pro-inflammatory genes. Epigenetic modifications may play a role. So this is regarding the genes, like you can see the important 100 genetic loci. 100 genetic loci. Then there are other factors like obesity, male predominance, RSV, rhino, and related to infections, RSV, rhinovirus, adenovirus, parainfluenza. Coming to environmental factors, this can predispose. Environmental factors, allergens, indoor allergens, these things: dust mites, furred pets, cockroach allergens, fungi, mold, yeasts. Outdoor allergens, pollens, fungi, molds. And indoor and outdoor, you can classify it like this. Seasonality, higher incidence in monsoon and winter. Acute attacks are less common in summer. So monsoon and winter, risk factor. Tobacco smoke, increased risk. Air pollution, increased risk. What are the key components? Nitrogen oxide, ozone, sulfur dioxide. For food allergens includes grapes, banana, guava, citrus fruits, and ice creams. Could be anything. You can include shellfish. Shellfish, no. Shellfish is something else. But it's for something else. Yeah, we could include that, I guess. And anaphylaxis, that's a different one. Pets, saliva, urine, and pet dander trigger asthma. So this could be a part of this. What's that? Allergens. Like allergens is subdivided into, like, they have repeated it, but it's fine because it is important. Next, coming to the pathophysiology. Exposure to allergens leads to sensitization activation of B lymphocytes to produce IgE. So there are these cells in the antigen presenting cells which get exposed to allergens, and these come and activate the B lymphocytes. B lymphocytes release IgE. IgE go and they go to this one mast cells, and these mast cells release different inflammatory mediators like the histamine and all that, and there are multiple mediators like this: histamine, leukotrienes, prostaglandins, and this is the acute phase. Close this for a while. I'll just finish this off. So in acute conditions, meaning right now he had it for the first time, he has it for the first time, then memory B cells are also formed when the antigen presenting cells are presenting to it. And when the next time something similar happens, these B cells, which are memory cells, these also cause the IgE to be released, and eventually there is histamine and other mediators. So overall, what do they cause? Bronchoconstriction, mucus hypersecretion, plasma leakage, edema, airway remodeling, and everything, the main pathology. So just know what these cause and everything. We can list it down here. And chronic inflammation leads to structural changes. What are the structural? Mucous cell hyperplasia, subepithelial fibrosis, subepithelial, under the epithelium, angiogenesis, and smooth muscle hypertrophy. Submucous cell hyperplasia, subepithelial fibrosis. So fibrosis meaning dead, keep repeating damaging the area, and that causes fibrosis. Angiogenesis, keep repeatedly damaging the area, it causes increased blood vessels there, and smooth muscle hypertrophy. So then what happens? Easily it can go spasm and all. So the thing is, better to stop this thing right now. What is it? The video, and then I'll be coming back later to continue on the rest of the aspects. Then we'll go on to CVS 2. But right now let's see, wait a second, how much is remaining? This, and then there is this. If I do one more session, I can possibly finish RS right now, meaning after 10 minutes. So maybe better to do it, finish it off now. Anyways, why to push it off? Yeah, I'll do one more session of 50 minutes. First, I'll take a break, and after that, I'll come back to finish the asthma, entirely asthma, status asthmaticus. Then we'll go to CVS. We'll see how much of CVS can be finished within 1 hour, within 50 minutes. Sorry, it will be less than 50 minutes, obviously. And then we end the entire video, and that's it for now. I'll start the timer. You can take a break. I'll take a break. So let's continue and let's finish this RS section. So where are we right now? We are in pathophysiology. We finished pathophysiology. We are in clinical features. Let's see if the mic is on. Yes, camera is on, and the timer. Yeah. So clinical features: recurrent dry intermittent cough, worse at night or early morning. So dry intermittent cough, worse at night or early morning. So night time, AM disease. Episodes of cough, wheezing, chest tightness and retraction. Cough, wheezing, airway closure, and chest tightness and retractions. Post-stressive vomiting after coughing vigorously. Where else is this seen? Pertussis. So advanced abdominal pain due to excessive work of breathing. Afebrile wheezing. Afebrile, think of superimposed viral infection. So there is no fever, but there is wheezing, which has been mentioned again. Recurrent exacerbation with seasonal variation, exercise induced nocturnal asthma. Next, coming to investigations, there is based on clinical diagnosis, asthma is diagnosed based on history and examination. In preschool children, more than 3 episodes of wheezing within a year, family history of asthma or atopy. Afebrile episodes, persistent cough more than 2 weeks responding to bronchodilators. So this is for preschool children. More than 3 episodes of wheeze within a year, family history of asthma or atopy, afebrile episodes persistent greater than 2 weeks responding to bronchodilators. School going children is the next one. Spirometry used to monitor asthma and treatment response. Measures forced vital capacity, FEV1 and FEV1 to FVC ratio is spirometry. In this particular case, since it's an obstructive disease, low FEV1 and FEV1 to FVC ratio is less than 0.8%. Next, coming to bronchodilator response, improvement in FEV1 greater than 12%. FEV1 is low, it increases by 12%, that is one of the tests, and 200 ml after beta agonist inhalation. Beta inhalation that causes improvement in FEV1 and 200 ml increase in the number. And peak expiratory flow rate. So expiratory flow rate and at its topmost value, what is it? Greater than 50% increase after this inhalation beta agonist and 15% decrease post exercise. So exercise decreasing it. Then blood investigation, eosinophilia suggestive of allergic asthma and elevated total and specific Ig levels. Chest X-ray not required unless ruling out other conditions. Findings: bilateral hyperinflation, prominent bronchovascular markings. Then skin prick testing, gold standard for identifying specific allergens. So these are the investigations. Clinical diagnosis in preschool children and in school going. We have different measures of finding out whether they have asthma or not. And over here under school going, we have spirometry, bronchodilator response, peak expiratory flow rate, blood investigation, chest X-ray and skin prick testing. And what is the treatment? Finally, education and environmental control. It has a genetic background. So what do? You educate the parents about the disease and medication use and avoid the allergens, strong odors, smoke, dust, pet dander. Keep indoor plants to absorb volatile organic compounds. Under pharmacotherapy, relievers, controllers, and relievers include SABAs, which is salbutamol, which used for immediate bronchodilation, and anticholinergic agents, ipratropium bromide with salbutamol. Now I feel that better I should have included the doses too, because asthma is like very common illness, right? So better to include the doses. I'll see in case I get time in the future to add anything here, I'll make sure to add the doses too. but it is quite hard to remember, but since it's a common illness, better to add the doses. Anticholinergic agents, ipratropium bromide used with salbutamol. Controllers, so relievers, it relieves immediately. Controllers, control future episodes. Corticosteroids, inhaled corticosteroids is number 1, systemic corticosteroids number 2, long acting beta agonist is number 3, leukotriene receptor agonist LTRA is 4, mast cell stabilizers is 5, anti-IgE monoclonal antibody is the last one. First one, ICS, inhaled corticosteroids. What are the names? Budesonide, fluticasone, mometasone. First line treatment, persistent asthma, reduce frequency and frequency of exacerbations. Budesonide, fluticasone and mometasone. Systemic corticosteroids, there is prednisolone and methylprednisolone, used only in severe cases. Long acting beta agonist LABA, there is salmeterol, formoterol, used an add-on therapy for inhaled corticosteroids. Salmeterol, formoterol, that is long acting. Then leukotriene receptor antagonist, there is montelukast, zafirlukast. Montelukast greater than 1 year, zafirlukast greater than 5 years. M for mono, mono means 1, greater than 1 year, zafirlukast greater than 5 years. Then mast cell stabilizers, there is cromolyn and nedocromil, which is also used. Then there is IgE monoclonal antibody, which is omalizumab, specific for IgE related omalizumab. Then for children greater than 12 years, moderate to severe asthma, and given subcutaneously every 2 to 4 weeks. Stepwise treatment of pediatric asthma, less than 5 years, greater than 5 years. Step 1 is, I think this is according to the, I feel it is according to the, no, GINA guidelines, that's in medicine. This is from the textbook. So step 1 is intermittent asthma, give SABA as needed. Short acting beta agonists, which are the salbutamol, which is this salbutamol. Then there is LTRA or low dose ICS, low dose LTRA leukotriene antagonist, receptor antagonist, montelukast, zafirlukast, or budesonide, fluticasone, mometasone. Budesonide, fluticasone, mometasone. And then step 3, moderate persistence, low dose ICS, leukotriene receptor antagonist and double ICS. That is in case of less than 5 years. More than 5 years, you can also give theophylline. Theophylline, make sure that you ensure that the dose is strictly maintained because it has low therapeutic index. And ICS, once again, what are those? Budesonide, fluticasone, mometasone. Budesonide, fluticasone, mometasone. Then step 4, that is severe. So we are done with moderate. Then severe, it is medium dose ICS. So till now we are doing low dose ICS. Now it is medium dose ICS along with LTRA, montelukast, zafirlukast. For adult greater than 5 years, it is medium dose ICS, that one budesonide, fluticasone, mometasone plus LABA. LABA, what are those? Salmeterol, formoterol. So LABA we started from here actually. LABA, LTRA, theophylline. We are again doing LABA, LTRA, theophylline. LABA is salmeterol, formoterol. Then finally we have oral steroids for less than 5 years or anti-IgE, which is omalizumab, and for greater than 5 years there is high dose ICS and immunotherapy. And so this is a general idea of the treatment, but more needs to be done, specifically looking at the doses. Doses are though it is hard to remember, we need to, but here there is one doses section for status asthmaticus. There is one doses section for epilepticus also, status epilepticus. Anyways, I'll make sure to add the doses in this one, bronchial asthma. Coming to status asthmaticus. Status asthmaticus is a severe prolonged exacerbation that does not respond to standard therapy with bronchodilators and corticosteroids. severe prolonged exacerbation of asthma. Severe means very bad, intense, and prolonged. The duration, intensity and duration is very high and does not respond to bronchodilator and corticosteroid, which were the mainstay of treatment in the normal asthma. It is a medical emergency and can lead to respiratory failure and death if not treated early. Increase in symptoms such as cough, wheeze and breathlessness and severe airway obstruction lead to hypoxia, hypercapnia and acidosis. What are the complications? So we have divided into proper sections. So based on this is the classification of that. So mild, moderate, severe and intermittent respiratory arrest, that is life threatening in nature. So based on the symptoms. So symptoms we have color, sensorium, respiratory rate, dyspnea, accessory muscle use, pulse rate, pulsus paradoxus, rhonchi, SpO2, PEFR. So we'll go each of them one by one in order so that we can classify it properly. First one, number 1, for mild we shall see the color. Color is normal and sensorium is also normal. Respiratory rate is increased in case of mild. Dyspnea is absent. Accessory muscle use is muscles are not used. Pulse rate less than 100, which is fine, and pulsus paradoxus absent. Let's see what pulsus paradoxus about this. I think it's related to inspiration expiration meaning. It is inspiration expiration most probably. Yeah, during the inspiration the systolic blood pressure drops, exaggerated drop in systemic pulse pressure during inspiration because of increased venous return, and right atrial which compresses the left ventricle. So what are the causes? Cardiac tamponade, obstructive pericarditis, severe asthma, COPD. See, this is the one, severe asthma. It's one of the causes for. So hyperinflated lung, increase the intrathoracic pressure, reducing left ventricular filling. So left ventricular filling could be either affected by the heart or the lungs, and in this particular case the lungs are affecting it because of hyperinflation. Why there is hyperinflation? Because it is an obstructive disease, obstruction to the airflow back out of the lungs. Coming back, yes, we have seen pulsus paradoxus, it is absent. Rhonchi is moderate. Let's see what rhonchi is again, because personally for me the rhonchi and all that musical note, non-musical gets confusing very quick. Low pitched coarse rattling sound heard over the lung, especially caused by airflow obstruction due to mucus and secretions in large airways. Snoring and gurgling sounds. So seen in obstructive lung disease. Obstructive lung disease, snoring or gurgling sound. So that is moderately present in case of mild, and SpO2 is good, PEFR is greater than 70, peak expiratory flow rate. Then moderate, what is it? What changes do we see? First one is normal, second one he is anxious, third one it is increased just like this one, and dyspnea is moderate which was absent previously. Accessory muscle use is there, 100 to 120, and here 10 to 20, same thing, 10 to 20 you put it here, and rhonchi are loud, and SpO2 has slightly decreased by 5%, and peak expiratory flow rate is 40 to 70, like 30% variability. And there is severe asthma, where there is patient is pale, agitated, like rather than anxious is more of agitated type. Increased respiratory rate is like more increased. Dyspnea is severe, usually accessory muscle use is usually present and greater than 120 per minute of pulse rate. Pulsus paradoxus 20 to 40 millimeters of mercury, 20 to 40, and then rhonchi are present throughout. Rhonchi are snoring or gurgling sound seen in COPD because of mucus and secretions, and SpO2 less than 90, and this is less than 40, like rapidly decreased. See, there are 30% and others less than 40%. Now finally imminent respiratory. So this is the fourth class, imminent respiratory arrest, which is life threatening. Cyanosis or drowsy, we went from pale to cyanosis and drowsy. Sensorium went from agitated to drowsy. So anxious, agitated, so levels have increased, now it has decreased. Respiratory rate has decreased, now it is decreased. Paradoxical respiration, dyspnea. Respiration, what is paradoxical respiration? We need to know what the thing is. Let's check it out. Abnormal breathing, there is a breathing pattern where chest and abnormal movements are opposite to normal during respiratory cycle. So chest moves forward, inward instead of outward during respiration, inspiration, and expiration it's the opposite. Accessory muscles are absent and bradycardia, impending failure. Impulsus paradoxus, absent. So this is suggests failure of respiratory failure. So bradycardia is seen just the opposite to what's happening previously, and rhonchi are absent. SpO2 less than 80% and PEFR less than 25. Management of status asthmaticus. General measures: allow the child to sit upright. Assess airway, breathing, circulation. Avoid antibiotics unless signs of infection. Perform chest X-ray if consolidation or atelectasis is suspected. So ABC, sit upright. ABC, antibiotics is not preferred, no to antibiotics. Chest X-ray is done. If consolidation or atelectasis is suspected, no role of routine mucolitis and NPO. Oxygen therapy, face mask and continuous oxygen monitoring. Now coming to the drugs along with the doses. Inhaled beta 2 agonist, and which is salbutamol, 0.15 to 0.2 milligram per kg, minimum 2.5 milligrams, nebulized every 20 minutes into 3 doses, then every 1 to 4 days, 1 to 4 hours as needed. Dilute with 3 ml normal saline. Systemic corticosteroids, 0.5 to 1 milligram per kg every 6 to 12 hours. 0.5 to 1 milligram per kg, 0.5 to 1 milligram per kg every 6 to 12 hours for 3 to 7 days. Very important to remember the doses, especially for this. During exam, due to some reason, I keep forgetting this. Anyways, switch to oral, one stable. So it was not oral. It was IV, probably. No, it was this thing, nebulization, probably, yeah. Not particularly sure. Anyways, anticholinergic, ipratropium bromide, 0.5 mg nebulized. It is nebulization, yes. Every 6 to 8 hours, used as adjunct therapy along with the previous ones. 0.15 to 2 for this one, 0.5 to 1 for this one. Anticholinergic, 0.5 milligram nebulization. Then adrenaline 1:1000, 0.01 milligram per kg SC or IM, repeat in 15 to 30 minutes, used in severe cases. Theophylline, loading dose 5 milligram per kg IV over 20 minutes, then 1 milligram per kg per hour. Monitor serum levels because this has low therapeutic index. Loading dose 5 milligram per kg per hour over 20 minutes. 0.01 milligram per kg subcutaneous IM. That is magnesium sulfate, 25 to 40 milligrams per kg IV bolus over 20 minutes for severe V's or monitor asthma. Terbutaline, selective beta agonist, loading dose 22 to 10 microgram per kg IV. Then anyways, this thing is hard to you need to look at it repeatedly. So I'll just read it out right now once again, like everything. Then after that, it's we need to make sure that we go through it again. Requires for continuous cardiac monitoring. This is terbutaline, 2 to 10 microgram, micro, unlike the rest, microgram, selective beta agonist. Then 0.1 to 0.4. So first one is inhaled beta 2, 0.15 to 2 every 20 minutes times 3 doses, then every 1 to 4 hours. Systemic corticosteroids, 0.5 to 1 milligram per kg 6 to 12 hours. Next is anticholinergics, 0.5 milligram nebulized 6 to 8 hours. Then adrenaline 0.0 milligram per kg SCIM maximum, 0.5 milligrams repeated over 15 to 30 minutes. Then loading dose 5 milligram per kg over 20 minutes. Magnesium sulfate 25 to 40 milligrams. Bolus 20 minutes. Even as I am explaining it, it's getting harder and harder. It's like unless you need to repeatedly see it every single day, like put it on the wall or something. Yeah, it's fine. Anyways, indications of intubation: cardiac arrest, respiratory arrest, and let's see if there is a way to remember this in ChatGPT. Oh, can't add this. Can you? Yeah. How to remember the doses? Inhaled by 15-20 for lungs, 15-20 for lungs, half to 1 of weight for systemic corticosteroids. Let's see, I'll add this thing for this. Speeds 4. Speeds 4. Anticolon is half for bronchi. Oh, okay. It is acting on the bronchodilator half. Yeah, trick. EpiPen rule 0.01. EpiPen 0.01. Epi sounds like 0.01. How does it sound like? Max 2.5. Epi. Happy 0.9. 5 to start, 1 to maintain. 5 to start, 1 to maintain. It's like caffeine, start with 5 milligram, then maintain at 1. Okay. Theophylline is like caffeine, start with 5 and with maintain with 1. Magnesium sulfate 25 to 40 milligrams per kg IV. Then terbutaline 2 to 10, then jog at 0.1 to 0.4. I'll just add it here. I don't know how useful it would be. Maybe somewhat useful. Like at the end, we just need to know a little, right? A little of dose everywhere. There's some numbers. Hopefully, it will help in that. Otherwise, it's hard without any kind of memory aids. Indication of intubation: cardiac arrest, respiratory arrest. So beyond this. Complication: acute respiratory failure, pneumothorax, pneumomediastinum, cardiac arrest due to severe hypoxia, lactic acidosis from respiratory muscle fatigue. And this is how we have come to the end of respiratory system, and I am just looking at that, how many things are done. So we are halfway there. Halfway meaning now it is actually not much. Like CVS is the biggest one and CNS is the biggest one. In the middle, that is kidney. Rest of it is actually it would go pretty quick. What time is it? Half an hour remaining. We'll see how fast we can do this. So VST, that PDA, then tetralogy of Fallot. This has been divided in two sections actually. One is TOF proper, and then there is cyanotic spells, because cyanotic spells is somewhat important. Then there is rheumatic fever, conjunctive cardiac failure, infective endocarditis. We'll start. So ventricular septal defect. So there is ventricular septum is like consists of two parts, the membranous septum and there is muscular septum. So most common congenital heart disease, that is number one. And coming back to this one, septum and membranous part, perimembranous VST, most common type, and there is muscular septum, 20% of the cases. And muscular septum further divided into trabecular VSD divided into inlet, mid, apical, posterior, conal types. Inlet, mid, apical, posterior and conal types. Swiss cheese VSD occurs when there are multiple CVS. Yes, yeah, and these are some terms related to VSD, meaning some basic anatomy parts and all that. And muscular septum, inlet, mid, let's see, inlet, mid, apical, posterior and conal types. It's just the name, but the most common type is the membranous, perimembranous VSD. And Swiss cheese is another one with multiple muscular septal defects, and outlet VSD is found near pulmonary and aortic valves associated with aortic insufficiency. Found near pulmonary aortic valves, often associated with aortic insufficiency. Coming to hemodynamics proper, the left to right shunt depends on size of the defect. Larger defects have higher shunting. Pulmonary vascular resistance, so larger the defect, higher the shunting. And pulmonary vascular resistance, increased PVR reduces left to right shunting. So to this thing, to conceptualize it, so shunting basically means left to right to left. Right to left. It could be also the opposite in Eisenmenger syndrome, but shunting is like rather than flowing through the normal resistance and all that, it going the place where there is less of resistance. So larger size, no resistance at all, so it passes very quickly. And pulmonary vascular resistance is increased PVR reduces left to right shunting. So increased PVR, increased pulmonary vascular resistance. So when the pulmonary vascular resistance is high, so what happens is left to right. So what happens is less of blood going to the left side. Less of blood to the left side, and because of that there is less of left to right shunting. And in small VSD, minimal left to right shunting occurs. So obviously in large VSD, significant blood volumes overloads the left atrium and left ventricle, leading to left ventricular dilation. So what happens is like shunting happens from this one. What is that? A left ventricle, let's see, VSD. So shunting happens from left to right, lots of pressure here, nice blood here, lots of blood, goes up into the pulmonary side, very nicely oxygenated, comes back into the left side, and left side it enters, and because of that lots of blood in the left ventricle and left ventricular dilation. That's what it means, nothing much. If untreated, progresses to pulmonary hypertension, Eisenmenger syndrome can occur. So what happens is lots of blood in this particular region. Then what happens, like you are passing a lot of blood through this thing, right? What is it? Pulmonary circuit. So because of that there is lot of pressure in the pulmonary circuit, and because of that this thing increases, the pressure in this thing increases, then opposite happens. What is it? From the right side to the left side. So coming to the classification, so it is small. So for this specific, it's better in case you watch some proper lectures on YouTube or some Marrow or something of that sort, because this requires proper in-depth understanding. Cardiology entirely, like even medicine and pediatrics, I would personally suggest, despite I am taking this up, I would suggest you to go through some other lectures, because this one might not be complete whatever I am teaching. This is exam related. Cardiology, that's a subject wherein you need to have a holistic understanding of it's like a proper mechanical engineering type. If you don't have the understanding of one specific part, the entire thing becomes useless. You can't understand it properly, and I doubt I am that good to explain everything and to understand everything. I'm just doing this as much as I can, to trying to understand and trying to explain. Yeah, coming to classification of VSD based on size and hemodynamics. A small, moderate, large VSD, and large VSD again with high PVR, pulmonary vascular resistance. So this is what I mentioned the last time, right? The left heart is receiving lots of blood is passing through the pulmonary circuit. So because of that, eventually what happens, lots of pressure in the pulmonary circuit. So pressure in the pulmonary circuit, what happens, there is more pressure in the right heart, because right heart needs to push through a lot of blood column in the pulmonary circuit, and this pushing through, because of that, more pressure generated in the right ventricle, and this right ventricle has a hole in it which can let blood pass through the right to left or left to right. But in this particular condition, when there is very high VHD, from right to left it happens, meaning lots of blood in the left, lots of pressure in the right heart, blood goes into the left heart, which is deoxygenated type. So right heart received deoxygenated, right? So it is the opposite. So I am looking mainly at this because this is somewhat a very complicated scenario where opposite of everything happens, whatever is here. And there is right to left shunt, as I explained, and sinus and pH, like pulmonary arterial hypertension, like I mentioned earlier. Pulmonary artery, blood that is moving away from the heart into the pulmonary circuit, that is causing arterial hypertension, like lots of blood, right? And cyanosis meaning peripheral areas that are, because there is right to left shunt, deoxygenated entering the oxygenated chambers, causing cyanosis in the periphery. And CX, chest X-ray, decreases left ventricular volume, and left ventricular hypertrophy disappears, right ventricular hypertrophy increases. So earlier there was left ventricular hypertrophy, but now there is the opposite. And why was the left ventricular hypertrophy present? We will learn it here in the small VHD, moderate, and these three sections. So now we will come to small VHD, what it is. It's a minimal shunting this thing, and all the sizes are normal. Volume overload is not there, everything is normal. Clinical features, asymptomatic with a murmur, and normal features. So murmurs we have discussed it here. Chest X-ray is normal, ECG normal. So this is small EHD, everything is normal except one small murmur and little bit of volume overload. Then there is moderate VHD, little bit of bigger hole between the right and left ventricle. Moderate shunting, dilated pulmonary arteries, left atrium. This one, right? What is it? Pulmonary left atrium and left ventricle. So lots of blood going through the pulmonary artery, left atrium and left ventricle. So everything is dilated. Volume overload, yes, there is a lot of volume overload because lots of blood is passing through the moderate sized this one, and then there is a growth delay, holosystolic murmur through the between the gap between the hole, the shunting, and there is growth delay, and left ventricular enlargement is seen. Left ventricular enlargement, why? Because lots of blood is coming, it needs to force the blood out of it. So whatever I explained here earlier, it is in the left side, latest it is in the right side because of opposite Eisenmenger, but here it is the other, earlier it is just the left ventricular hypertrophy. Then there is now this is this state, but low PVR, meaning pulmonary arterial hypertension is not there here in this particular case. So in that particular, there is lots of dilation. It's like extreme case of this one, like severe left ventricular overload. It needs to push through a lot of blood, and congestive cardiac failure, hyperdynamic chest, and biventricular enlargement, pulmonary congestion. So these things, and then finally biventricular hypertrophy, meaning both the sides are working, and after a while in the last stage right side becomes more predominant. We have 16 minutes, let's see how much. Clinical features, there is small, so harsh holosystolic murmur, common everywhere, holosystolic murmur, the small and moderate, asymptomatic, and lower sternal border which has the between this thing, what is that, the septum, interventricular septum, and this particular diastolic rumble at the apex with mid diastolic rumble at the apex, and large VHD which has low pulmonary vascularization, features of CCF. So you know from the left heart it is going to the right heart almost, and it is trying its best to fill things up. And what is the thing? The right ventricle left ventricle is filling up the right ventricle, and that is what is congestive heart failure feature. Tachypnea, poor feeding, sweating, failure to thrive, hepatomegaly, precordial bulge. So all these features, it's like general feature of congenital heart disease, seems like that. And large VSD, high PVR, pulmonary hypertension, as I mentioned earlier, key feature, cyanosis and single loud S2. This one, single loud S2 is for Eisenmenger. And then for ECG findings, we have small VSD normal, left ventricular is hypertrophy is left axis deviation, meaning more the muscle mass in one particular region, more the electrical activity in that particular region, more the axis deviation in that particular region. And the same thing in this particular, when both the sides are in like same this thing, it is like in the middle, but when the one of the sides is more hypertrophic, this thing, the axis of the ECG deviates more towards that. Yeah, same thing over here, same principle can be applied everywhere. And ECG, small VSD, X-ray, small VSD, no cardiomegaly, moderate VSD, LV enlargement, large VSD, biventricular, and Eisenmenger, cardiomegaly decreases and pulmonary artery dilation. 2D echography confirmed VSD diagnosis, size, location, magnitude, the anatomy is seen through this. And then finally, treatment. Medical management for small to moderate VSD. There is diuretics, furosemide, spironolactone to manage CCF, ACE inhibitors like captopril, enalapril reduces afterload and LV overload, and nutritional support for failure to thrive. Like volume overload is the main key thing, and then nutritional support for general congenital heart problems. Surgical management for large VSD. Indications of surgery: large VSD in infancy 6 months before, 6 months if the heart failure persists, pulmonary artery pressure greater than 50%. So these are the indications: large VSD, pulmonary arterial hypertension, and QPQS ratio. QPQS, need to know what that is. Ratio meaning in VSD. Represent pulmonary blood flow is to systemic blood flow, it is high. See, pulmonary into systemic is high. So then what you do? Primary closure with patch, open heart surgery, contraindicated with in pulmonary vascular obstructive disease, Eisenmenger syndrome. What are the complications? Congestive cardiac failure due to high volume, left to right shunting. Pulmonary hypertension, yes. Aortic regurg due to prolapse of aortic valve cusp into the VSD. So due to some pressure related effect maybe. And arrhythmias, right bundle branch block, AV conduction defects after surgery. Right bundle branch block. Okay, so VSD is done, one of the congenital heart diseases, very important. Then coming to PDA. PDA, there is we have the definition, overview of what it is. PDA occurs in 10% and more common in preterm infants. Why is that? Because fetal circulation, in fetal circulation PDA forms the most important part. There is higher incidence in female than male, okay, epidemiology. And then the ductal arteriosus is the fetal structure that connects the pulmonary artery to descending aorta. PDA to PDA heart. So you can see the aorta, the pulmonary artery. These are the pulmonary arteries away from the heart into the lungs, and this is the descending aorta, and there is this connection which is patent ductus arteriosus. Failure to close after birth results in persistent patency leading to left to right shunting. So why left to right? Because left heart is aorta coming out of the left heart. Left to right meaning left from aorta into the pulmonary arteries, which is the right side of the heart, right section of the heart, which is the right ventricle, pulmonary artery. So there is conduction happening, blood flow, shunting. Pathology, PDA is one of the cone shape located 10 mm distal to the origin of the left subclavian artery connecting proximal pulmonary trunk to descending aorta. Yeah, some anatomy with numbers. In fetal life, it allows oxygenated blood from the placenta to bypass the lungs to enter the fetal circulation. So initially it is in this one, right? What is it? Right heart is the one that receives the oxygenated blood, and then from the foramen ovale it goes into the left heart, and from the left heart it goes into the aorta, and like that. Yeah, and that is the one side. I didn't mention about on the right side. What happens is the blood comes in, and whatever blood is coming in, it goes up into the pulmonary artery, but it doesn't have to go into the lungs, shouldn't be going into the lungs. From the lungs, before it goes into the lungs, so the oxygenated blood comes up from this one. What is it? This one, the hepatic IVC comes over here and it releases it here. So half the nice blood goes into the left atrium, the foramen ovale. Little bit goes over here, and this blood goes into this, and there is no this thing over here. What is lungs shouldn't be working, so it's high pressure environment in the lung area, so all the blood gets shunted into the descending aorta. That is what it means. Persistent afterbirth functional closure within 24 to 48 hours due to increased arterial oxygenation and prostaglandin metabolism. Persistent patency leads to increased pulmonary blood flow, left atrial and left ventricular overload, and risk of pulmonary hypertension. What are the hemodynamics? The degree of left to right shunting depends on size of the PDA, pulmonary vascular resistance. Small PDAs have minimal shunting, while large PDAs cause significant volume overload. Because shunting is happening, right? Yeah. So, and there is Eisenmenger syndrome here too. Whenever there is left to right shunting with enough of pressure in the pulmonary circuit, there is reversal of shunting. So size of PDA matters, and so because of that there could be volume overload. Next one is PVR, pulmonary vascular resistance. If PVR remains high, shunting is reduced. Small PDA, large PDA. Small asymptomatic, large leads to left atrial and ventricular dilatation and progress to pulmonary hypertension, and just like VSD, exactly like VSD, but the shunting, the place of shunting is different. Rather than being in the ventricular septum, it is further outside, meaning blood, rather than mixing in, rather than happening happening here, it is happening here. Lots of blood going here, left heart more pressure going here and mixing here, rather than more pressure here mixing here itself. It's going like this and mixing, exactly the same thing. If this size is bigger, eventually more blood into the pulmonary circuit, Eisenmenger syndrome. More Eisenmenger syndrome, what happens? Pressure over this side increases, more pressure on this side rather than this side, and this thing pressure increases, and then getting back into the fetal circulation type. More blood, more deoxygenated blood going into the descending aorta, and what? Everything. But here I doubt it goes to the central this thing. It may be descending aorta, right? So that is this thing. Particularly that's what leading to cyanosis, particularly lower extremities. So that is differential cyanosis, lower extremities only, because it is shunting into the descending aorta. What are the clinical features? So now we look at the clinical features properly. Small PDA, asymptomatic, incidental finding, continuous murmur during this thing. Continuous machinery murmur, that is what we call continuous machinery murmur at left upper sternal border. Left, this is my left side, upper sternal border here. Incidental finding, large PDA, congestive cardiac failure, and there is tachypnea, poor feeding, sweating, respiratory infections, bounding peripheral pulses, wide pulse pressure, hyperactive precordium, systolic thrill, and upper this thing, and loud P2 in pulmonary hypertension, like Eisenmenger syndrome, right? Even in VSD we heard second heart sound increased. apical diastolic rumble due to relative mitral stenosis. Additional points: apical diastolic rumble. So in addition to loud machinery murmur, these things also. Then finally investigations. If we understand that, this becomes CC. Chest X-ray, normal findings, large PDA, cardiomegaly, increased pulmonary vascular markings. So same thing, just like ventricular septal defect, but here positioning of shunt is ahead, downstream. ECG findings, same thing, left ventricular hypertrophy, axis deviation. And finally echocardiogram, gold standard for PDA diagnosis. Suprasternal view. So suprasternal view is the key thing. Left atrium and left ventricular dimensions indicate left to right shunting severity. Left atrium and left ventricular, right and left side ventricular dimension indicates this thing. What is it? The kind of shunting it is. The severity of shunting. Why? Because small PDA, large PDA before the Eisenmenger, this thing, it is large and lots of hypertrophy in the left side, but opposite the case when pulmonary vascular resistance increases, right side hypertrophy is present. Treatment: medical management, small PDA, spontaneous closure for 6 months, preterm and preterm infants, indomethacin, ibuprofen for PDA closure, prostaglandin inhibitor to reduce ductal patency. Indomethacin for PDA closure, prostaglandin inhibitors to reduce ductal patency. Then surgical closure, we have this one is most commonly done. If medical therapy fails, this thing fails, indomethacin fails, ibuprofen fails, prostaglandin inhibitors fail, we have PDA ligation, symptomatic large PDA with CCF. So CCF like features, lot of left ventricular to right left to right shunting, failure of medical closure, recurrent pneumonia and pulmonary congestion. So lot of blood in the pulmonary circuit, right? So because of that, increased predisposition to pneumonia and all that. Echocardiographic evidence of left atrial, left ventricular overload. Procedure: posterolateral thoracotomy, ligation of hemoclip, placement of ligation or hemoclip placement on the ductus. Non-surgical catheter closure indicates symptomatic with CCF, so it's non-surgical. Case 1 with surgical, and the incision was posterolateral thoracotomy. In this case, this is contraindicated in Eisenmenger or severe PAH. What is the procedure? Gianturco coils or Aplatzer duct occluder are placed via catheterization. So different names, just the names are a little bit different, but overall the principles, the main thing, medical management for pediatrics, it is good enough. That is in my personal opinion, but this one's better to know the names to write it. Right, Gianturco coils, Aplatzer duct occluder. Then complications include injury to recurrent laryngeal, phrenic or thoracic duct. Complications: CCF due to volume overload, pulmonary hypertension, late presentation, endocarditis, bacterial infection of the PDA, arrhythmias due to atrial enlargement because of differential hemodynamics, differential cyanosis, as we have mentioned, as we have seen earlier. So this comes with this, we have ended the PDA also. Next coming to tetralogy of Fallot. This one is 2 questions actually, and let's begin. So 1 more minute remaining. Should we continue? Yes, let's finish the definition, at least a part of it. Definition: TOF, tetralogy of Fallot. So tetra meaning 4. 4 things happen here. It's a congenital heart disease, combination of 4 anatomical defects. One is VSD, we have seen VSD. Pulmonary stenosis. So pulmonary stenosis, like pulmonary vessels are there, pulmonary arteries. That pulmonary artery forms the right ventricular outflow tract, that is constricted, that is causing obstruction, and there is aortic override, meaning aorta is displaced over VSD, receiving blood from both the sides, right and left. So what is there? Deoxygenated blood also comes into the aorta. and right ventricular hypertrophy, thickening of the right ventricular wall due to increased workload of this thing. So right ventricular wall increases. What is that? Pulmonary stenosis. Pulmonary stenosis, like right ventricular outflow is obstructed. Right ventricular outflow is obstructed. So what happens? Right ventricle has to push more. So because of that, hypertrophy of that happens. So just by looking at this axis deviation, you can tell. Anyways, I'll stop the discussion here, and I'll close the video also. I'll take a longer break, and I'll start another video later on after some time. But right now I need to stop this. I have some work to. Anyways, in case you like this particular video, you can like it, and in case you have any suggestions, you can write it in the comments or in the Instagram. And in case you would like to contribute yourself to this project, you can message or show interest. Anything is fine. So that's it. Okay, then it's almost 4 hours. Okay, then bye bye.